Now we're going to cover the 4 parts of pharmacokinetics, and part 1 is drug absorption. First, let's start with the definition for drug absorption. It's really the process of entry of the drug into the systemic circulation from the site of administration. Here's how I want you to think about this. Always remember that absorption involves 2 compartments. Absorption implies that I'm going to place the drug into one compartment, and the second compartment is always going to be the blood. I'm watching the drug move from the first compartment into the blood, and that's how I know I'm dealing with the process of absorption. It always has to involve 2 compartments, with the second one being the blood. And that's why you can really miss this point if you're not careful. If I ask you what is the most rapid route of absorption, some people might answer IV. And the reason you would say IV is because you know how fast that route of administration is. The question really is, does IV administration involve absorption? Does IV involve 2 compartments? And you know the answer to that question is no. IV, you're placing the drug directly into the blood. And as a result, it does not involve absorption. That's why you can't answer that question with IV. So what is the most rapid route of absorption? It's inhalation. Inhalation. When you think about all those alveoli, how close they are to capillaries, that's a very rapid route of absorption. There are plenty of other routes that are fairly rapid as well. If you think about the sublingual route, how we take nitroglycerin, that's a very rapid route of absorption as well. Of course, if you take a drug IV, it's 100% bioavailable. It's all in the blood. On the other hand, if I take a drug by some other, what's called an extravascular route, something other than IV, there's a great chance that less than 100% of that drug is going to be bioavailable. Let's define that term. Bioavailability really defines how much of your dose gets into the blood. How much of the dose of your drug makes it into the blood. When I place it into the first compartment, how much of that drug makes it into the blood? By definition, that is bioavailability. When we look at the plasma level curves here, once again, when you see a graph, look at your axes. We're plotting time versus plasma drug concentration. And there are several terms that we want to look at here. First, notice the shape of the curve. Do you notice how we start low? We start basically at 0 as a plasma concentration. We increase over time to a peak, and then we fall away in the process of elimination, all done over time. So you would look at this graph and immediately conclude this must be an extravascular route of administration. In other words, it's not IV, because an IV curve would be shaped totally differently. When I give a drug IV, the graph is going to start up high. I'm going to give a bolus of a drug. I will start up high with my plasma concentration, and that will fall over time in the process of elimination. So the shape for IV totally different from what we see here. In fact, I can imagine that this is an orally administered drug. That's our most common way to take drugs anyway. Let's imagine that. If I take the drug orally, one of the terms that I want you to be able to define is lag time. When I take that drug and I start at time 0, there's a period of time where none of those drug molecules have made it into the plasma yet. So from time 0 until the first molecules show up in the blood, we call that the lag time. Now, just because the drug gets into the plasma does not mean it's working yet. If you follow the curve, plasma levels start to increase, but only when I get to this point defined as the minimum effective concentration is the drug actually going to work in the body. Notice, that's where I first see the pharmacologic effect, the MEC, the minimum effective concentration. So our second term is onset of activity. That's defined from time 0 until I reach the MEC. And the onset of activity does include the lag time because it starts at time 0. Once I've crossed the MEC, in the process of absorption, the drug continues to rise in the plasma. The levels continue to go up until I reach a peak. I reach the peak, and then I begin the process of elimination. And during that process of elimination, plasma levels are going to go down and eventually cross the MEC a second time. So here's our third term. It is duration of action. How about make it simple? Duration of action is the amount of time that the drug is above the MEC, from where I first cross it in the process of absorption to when I cross that number again during the process of elimination. That's the duration of action. Now think about this. Are there ways to manipulate the shape of this curve? Sure there are. I could change the process of absorption. We just covered ionization. Imagine if I did something to change the pH of the stomach. Any of you ever have upset stomachs and take antacids? So what are antacids like Tums and Rolaids? What are those going to do to the pH of the stomach? They're going to increase the pH of the stomach. How does that influence the absorption, let's say, of a weak acid? If it's a weak acid and I've raised the pH of the stomach, isn't it true that the weak acid is going to be less absorbed? So the shape of this curve, the curve is going to be depressed. It's going to shift to the right. It's going to be slower absorption for that weak acid drug because the stomach pH is higher. That means, for example, it's going to take longer to reach the MEC. My onset of activity is going to be increased if I'm taking antacids at the same time as a weak acid drug. But what if I took antacids and then took a weak base drug? With a higher pH in the stomach, the weak base is more likely to be absorbed. So the slope of this curve is going to be steeper. It's going to be increased. So I will reach the onset of activity faster if I'm taking a weak base drug and the stomach pH has been increased. Are there ways that you can change elimination? Sure, you may not want to, but we know that as we age, renal function declines. With declining renal function, for example, you're going to slow down the process of elimination. Which of these terms is that going to influence? Of course, it's going to be duration of action. If it takes longer to eliminate the drug, the duration of action is going to be increased. And that means you're going to have to make a dosage adjustment. If the drug lasts longer, you're going to have to lower the dose in patients with renal dysfunction. The concept of bioavailability. Remember, we've already defined this term by saying that it's the amount of drug, the amount of your dose, that actually makes it into the plasma. What we do to compare bioavailability is we compare the route that we're going to use to giving that drug IV. When I think about the term bioavailability, notice that we use the letter F for bioavailability. It doesn't really make any sense, does it? But if F possibly is standing for fraction, that's the way to remember. F could be the fraction of the dose that reaches the systemic circulation. So what is the F value for an IV drug? Since IV drugs are 100% bioavailable, their F value is 1. But other routes who are going to have a lower bioavailability, their F value is going to be less than 1. So what if I said, well, here's a drug, we give it, and its F value, its bioavailability is 0.8. First thing you know is the drug wasn't given IV. 0.8 tells you that 80% of that drug was bioavailable. And F, bioavailability, is a part of our dosing equations. If you have lower bioavailability, you're going to have to account for that by giving a larger dose compared to, say, what you would give IV. It's not as important to worry about the curve that you see here. The figure that shows you the comparison between an IV dose and, let's say, an oral dose, that's not as important as understanding the concept of bioavailability as it relates to dosing adjustments. The first pass effect has a major influence on bioavailability for orally administered drugs. Remember, the first pass effect refers to the first pass going through the liver. When you take a drug orally, it has to survive the liver in order to make it into the systemic circulation. Let's look at this example. Let's imagine that if you took 100 milligrams of a drug, you swallow that amount, that 100 milligram dose is going to go to the liver. Notice how it's going to get churned around in the liver. And we look and we'll see what comes out on the other side. What amount of that dose made it into the systemic circulation? Was it all of it? As you see in my example, if it was, that would be surprising for an oral drug to have 100% bioavailability. But if it did, its F value would be 1. If I swallowed 100 milligrams and only 80 milligrams made it into the systemic circulation, the F value would be 0.8. 80% would be bioavailable. So clearly the first pass effect through the liver influences orally administered drugs. It's why some drugs can't be taken orally. The example in your book is lidocaine. If I take lidocaine orally, for example, its first pass effect through the liver is going to be so significant, the amount of lidocaine that makes it into the systemic circulation is very, very low. Low enough, in fact, that it's not a useful drug to take oral. So we're going to give this drug IV. Let's take another example. We take nitroglycerin sublingually for an acute angina attack. Give me two advantages of sublingual nitroglycerin. One of those advantages, rapid absorption. You put the drug under your tongue, the mouth is very vascular. The drug is going to quickly move into the systemic circulation, and it's going to bypass the first pass effect. It's going to bypass the liver. So the two advantages are rapid onset and little to no first pass for a sublingually administered drug. The second part of pharmacokinetics, drug distribution. Of course, this involves the process of the drug being distributed throughout the body. The drug has been absorbed, it's in the circulation, it's now going to be distributed to the tissues. Of course, many drugs are bound to plasma proteins. That's a key component of drugs. They're lipid soluble, therefore they need a carrier in the plasma. So many of our drugs are going to bind to plasma proteins. The relationship of a drug binding to a plasma protein is shown on this slide. Notice that when a drug is bound to a plasma protein, it is inactive. So the bound form of the drug is inactive. It has to dissociate from the plasma protein into its free form in order to be active. Now this sets up, though, our first major type of drug interaction. Since most drugs are lipid soluble, that means most drugs are going to bind to plasma proteins. So what if you're taking more than one drug at a time, and those drugs both want to bind to plasma proteins? Well, there's going to be competition. I have two examples to illustrate this point. The first clinical vignette deals with the drug warfarin and sulfonamides. So warfarin is highly protein bound. Somewhere around 98% of the warfarin in the plasma is bound to plasma proteins, leaving only 2% free. Sulfonamides are also highly protein bound. So if you're on warfarin and sulfonamides, there's going to be competition for binding sites on plasma proteins. Most often you think about albumin as the major plasma protein. So let's imagine that for right now. There's competition for binding to albumin. In fact, compared to taking warfarin alone, when you combine warfarin and a sulfonamide, the free levels of warfarin are going to be increased because of the competition. Higher free levels of warfarin can produce a greater chance of warfarin toxicity. So that's the way this scenario would play out in the test question. Patient starts on warfarin. You've been monitoring them for some period of time. You're satisfied with their prothrombin time, for example, but some weeks later, maybe they start on a sulfonamide antibiotic. What's going to happen a little bit later on due to the competition? Higher levels of warfarin in the plasma, increased risk of toxicity. This patient might experience bleeding, bruising, blood in the urine, all signs of warfarin toxicity due to the higher levels of this drug in the plasma. Some of you might also be thinking, well, if the sulfonamide is competing, aren't the levels of the sulfonamide also going to be increased compared to the sulfonamide alone? And that's a good thought. Absolutely, that is correct. But with higher levels of sulfonamides, while there is an increased risk of side effects from that drug, it's just way more likely to see this question in a warfarin scenario where the toxicity is going to manifest as bleeding or bruising. So the side effects tell you what drug was causing the problem. The second example involves sulfonamides again, but this time with unconjugated bilirubin. Remember that unconjugated bilirubin binds to albumin. So here the sulfonamides are competing with unconjugated bilirubin. When the levels of bilirubin go up in the plasma, you get kernicterus and bilirubin encephalopathy in neonates. And this is a side effect of sulfonamides because of their competition for binding to plasma proteins with bilirubin. We sometimes talk about special barriers to distribution. When you think about the placenta, really don't think about this as an effective barrier to drugs, because the fact is that most drugs can cross the placenta. Now, I didn't say that most drugs are teratogenic. I didn't say that most drugs harm the fetus. I just said that most drugs can cross the placental membrane. When I think about this, if I think about a good, effective barrier, that would be the blood-brain barrier. The blood-brain barrier is permeable only to lipid-soluble drugs or very, very small drugs by molecular weight. If I take the examples of lithium and ethanol, lithium is the smallest drug we have, and even though it's positively charged, lithium can get into the CNS. That's because of its low molecular weight. It's so small it can get in. And also ethanol. Ethanol is an alcohol which is water-soluble, but it's small enough that it can actually enter the brain as well. You can follow this rule, that if a drug can cross the blood-brain barrier, it will easily cross the placenta. And occasionally those drugs are going to be harmful to the fetus. They can be teratogenic. If you take my two examples that I just gave you, lithium and ethanol, both of those can harm the fetus. Both have teratogenic effects. What if your job was to design a drug that would be safer in pregnancy? I always use the word safer instead of safe. How could you make a drug safer in pregnancy? Well, you can make that drug water-soluble. If you have a water-soluble drug, it's less likely to get into the placenta and affect the fetus. If the drug was large, size matters. Larger drugs here can effectively cross the placental membrane. What if the drug was protein-bound? That will increase the size of the drug, so if it's protein-bound, it's less likely to affect the fetus as well. In fact, I would love to be able to combine these properties. You can have a larger and a water-soluble drug. You can have a large and also perhaps a protein-bound drug. Notice, however, that water-soluble and protein-bound really don't go together. If a drug is water-soluble, it typically does not need a carrier in the plasma. It doesn't need to bind to plasma proteins. Drugs that bind to plasma proteins are the ones that are lipid-soluble. So it would be unlikely that you could develop a drug with all three properties, but if you had at least two of those, that would be a safer drug in pregnancy. The example in the text of propylthiouracil versus methimazole. The reason why PTU is used more in pregnancy compared to methimazole is it's more highly protein bound. Therefore, it's less likely to affect the fetus. The concept of apparent volume of distribution, abbreviated as V sub D, can be expressed in this equation. Volume of distribution is dose divided by C0, where C0 is the plasma concentration at 0 time, or in other words, it's the initial plasma concentration. This is an equation that you absolutely must know for your Step 1 exam. There aren't a lot of pharmacology calculations that are likely to show up on Step 1. This is one that is likely to show up. The good news is that it's an equation that only has 3 variables, and they're going to have to give you 2 of those variables in order for you to calculate and come up with a correct answer. The variables that they most often give you on the test are volume of distribution and plasma concentration, and you're left to calculate dose. So that again is good news. Volume of distribution is most often expressed in liters, and plasma concentration in milligrams or micrograms per liter. You multiply those two together, the liters cancel out, and you're left with an amount, which would be your dose. So again, if you use your math tricks, you can probably solve this equation pretty quickly. But let's think about it for a moment. What does the equation really tell us? It tells us that volume of distribution and plasma concentration are inversely proportional. Do you see that? They're inversely proportional. So if I give a certain dose of a drug, and most of that dose stays in the plasma, if my C0 is a higher number, that means my volume of distribution is going to be a lower number. So higher levels in the plasma are going to mean a lower volume of distribution. But what if I give a certain dose of a drug, and almost none of that dose stays in the plasma? If the plasma concentration is low, the volume of distribution is going to be high. So understand the relationship. That will help you to predict where is the drug in the body. And with volume of distribution, there are 2 answers. Either most of the drug is in the plasma, in which case you have a low volume of distribution, or most of the drug has gotten out of the plasma and gone to the tissues, and that means you have a higher volume of distribution. Things that are going to keep volume of distribution low are when the drug is highly bound to plasma proteins. If it's highly bound to plasma proteins, the drug stays in the plasma, therefore we have a low volume of distribution. If the drug is sequestered into the tissues, you're going to have a high volume of distribution. We use volume of distribution to calculate our loading dose, which we'll discuss later on. If you'll notice in the margin, we've got a note that talks about normal volumes, plasma volume or blood volume, extracellular fluid, and total body water for a healthy person weighing 70 kilograms. We like to call that person the ideal 70-kilogram man. So if I take a look at those values, maybe this will help you to put into perspective what I've talked about as a low or a high volume of distribution, because some people are uncomfortable with those terms. Here's the way that I think about it. Lower volumes of distribution are those that sound physiologic. The numbers on this slide are all physiologic values. So if I said a drug has a volume of distribution of 5 liters, 10 liters, or 40 liters, all of those could be real physiologic values. On the other hand, I would call those low volumes of distribution if they're physiologic. On the other hand, if I have values like hundreds of liters or thousands of liters, and there are drugs like that. There are drugs that have volumes of distribution of 500 liters, 2,000 liters. If I see hundreds or thousands of liters as the volume of distribution, obviously that's not a physiologic value, and obviously those numbers would be high volumes of distribution. What that really means is that those drugs are easily being sequestered into the tissues. They're probably bound up in the fat, and they're being stored there. That's what those high numbers are telling us. So if they're non-physiologic, those are our larger, higher volumes of distribution. When I look at my equation, volume of distribution is dose divided by C0. I need volume of distribution to be expressed as liters, though sometimes I see it expressed in a question as liters per kilogram. Here's a very important note for you. If I ever see volume of distribution expressed as liters per kilogram, there's no place for kilograms in my equation. The first thing that I want to do is multiply by the patient's weight. Find their weight in the question, multiply times the volume of distribution so that I can cancel out the kilograms. That leaves me with liters, which I then plug into my equation. The concept of redistribution basically says the drug has been distributed throughout the body, and now it's going to be redistributed. Probably the best example of this is the IV anesthetic thiopental. When you give thiopental IV, it's going to rapidly reach the brain. In less than a minute, you're going to start to see some effects from this drug. So it has a very rapid onset. But what most people don't remember about this drug is it actually has a relatively long half-life. Thiopental has a half-life of 9 hours. It doesn't last that long as an anesthetic, so what am I really saying? I'm saying the drug rapidly goes into the CNS, but then it gets redistributed. So where is a very lipid-soluble drug like thiopental going to go? Those very lipid-soluble drugs are going to redistribute to the fat. So thiopental has a longer half-life because it's being sequestered in the fat, but that's not the same as saying that the drug is going to work for 9 hours. When it's redistributed, you end up terminating the action of this drug. Redistribution is illustrated in this figure. So if I administer a drug, and let's say that that drug is thiopental, that's our example, the drug is going to go more rapidly into the CNS compared to the fat, even on initial distribution. Can you explain why? Why does that drug move more rapidly into the CNS initially compared to the fat? Well, this goes back to an earlier concept on vascularity. Who's the more vascular tissue? Is it the CNS or the fat? Obviously, it's the CNS. With greater blood flow, the CNS is going to get a higher concentration of the drug initially on initial distribution. So the drug moves into the CNS. It will then move back out of the CNS and be able to move into the fat. It can sequester into the fat. and its movement into the fat is going to occur basically down its concentration gradient. But what if I gave a second dose of thiopental? Assuming I've already given one dose of thiopental, when I give a second dose, the second dose is going to rapidly move into the CNS, again, greater blood flow. But when the drug goes to move into the fat with the second dose, the movement into the fat is even slower than it was the first time. Now, why is that? Obviously, it's because there is already some drug in the fat. I've changed the concentration gradient. With the second dose, the movement is even slower because I've got less of a difference there in the amount of drug in the blood compared to the fat. And keep going. What if you gave a third dose? Now the movement is even slower into the fat because of the accumulation. The storage of the drug in the fat has changed your concentration gradient. And if you're moving even slower into the fat, that means the drug will last longer in the blood and potentially means it goes back into the CNS, and you can prolong the effects of thiopental because you're saturating its storage site. So part 3 of pharmacokinetics is metabolism, sometimes called biotransformation. The rule on metabolism is that most often metabolism is going to take an inactive drug, converting it into its inactive form. Metabolism is going to convert an active drug into its inactive form. In fact, we can illustrate that in the following slide. So while we often think about metabolism as converting an active drug to an inactive drug, as shown on the first part of this slide, always remember that metabolism can even be an activating reaction, and that's shown in part 2 and part 3 of this slide. In fact, I can take an active drug and form active metabolites through metabolism. There's a note in the margin on benzodiazepines. This is a group that's very classic for forming active metabolites. Drugs like diazepam form multiple active metabolites, and that contributes to the duration of action of those drugs. Remember the third reaction here, where some drugs are prodrugs, which are inactive. Metabolism then converts them to their active form. But the rule is still the rule. Most of the time, metabolism takes an active drug, converts it to its inactive form, and the other two reactions occur less commonly. When we think about metabolism, we talk about phase 1 and phase 2 metabolism. I will tell you that I'm not a big fan of the terms phase 1 and phase 2, and the reason is because it sounds too much like a sequence. Phase 1 and phase 2 sounds like you always have to have a phase 1 reaction before you have phase 2, and that's not true. In fact, this does not predict a sequence of events. I can metabolize a drug by a phase 2 reaction and then metabolize it by a phase 1. I can metabolize it by phase 1 only. I can metabolize it by phase 2 only. So importantly, it's not a sequence. Probably a better term and maybe a better way to think about metabolism is that there are two types of reactions. There's the first type, which we call phase 1, and a second type, which we call phase 2. Phase 1 most often involves enzymes called cytochrome P450s. Cytochrome P450 enzymes are really a number of enzymes. There's about 13 families of P450 enzymes with about 100 enzymes total. And P450 enzymes are going to perform a series of oxidation reactions. In fact, the three types of phase 1 reactions: oxidation, reduction, hydrolysis. P450 enzymes, most of their reactions are oxidations. Remembering that there are a lot of P450 enzymes, this table illustrates just a few of those families, like the 1A2 and the 2C9 and the 2D6 and the 3A4 families. So not all of the families are represented here. We just picked a few select ones to show you in this table. I will tell you that even though this is an important table, it is impossible for you to memorize this table. Now, I understand some of you out there thinking, I can memorize it. I can memorize anything. But what you can't memorize off of this table are the substrates. If you look at the 1A2 family, we've only got a couple of substrates listed. 2C9 lists a couple of substrates. But look at 2D6. It says many cardiovascular and CNS drugs. We don't even list them all because they're too numerous. And notice 3A4 says 60% of the drugs in the PDR. 60% of the drugs in the physician's desk reference, that's about 700 drugs total that fit into that one box. So maybe the take-home message for 3A4 is that obviously is a very important set of P450 enzymes, because 3A4 metabolizes over half of all the drugs that we have. But there's no way you should even try to memorize any of those. They're just too numerous. So what do you have to focus on in this table? Focus on the concept of P450 inducer and P450 inhibitor. So if I say a drug is a P450 inducer, that drug is going to increase gene expression. It's going to increase gene expression. Let's take an example. If you smoke cigarettes, there are hydrocarbons in cigarette smoke called benzopyrenes. Benzopyrenes are P450 inducers. What I'm saying is this: if you're a smoker, because of those hydrocarbons, you're going to have more 1A2 enzymes compared to a non-smoker. And since I've got more enzymes because of the hydrocarbons in the smoke, any drug that I take that's metabolized by 1A2 is going to be metabolized to an even greater extent because I've got more enzymes. So let's say you smoke and you take the drug theophylline. A smoker is going to metabolize theophylline to an even greater extent due to more enzymes compared to a non-smoker. Now make that relate to plasma levels. Say it this way: a P450 inducer is going to lower the plasma levels of the substrate compared to somebody who's not on that inducer. So the smoking is going to lower the plasma levels of theophylline, which means in that smoker, I'm going to have to increase their dose of theophylline to get the same benefit. Now, the P450 inducer question, while it's important, it's just not as likely to show up on the test as the inhibitor question, because an inducer is going to lower the plasma level of the substrate. What is the inhibitor going to do? The inhibitor is going to decrease gene expression. And by decreasing gene expression, you'll have fewer enzymes for drug metabolism, and that means the inhibitor is going to increase the plasma level of the substrate. Why is that a more popular question? With higher plasma levels of the drug, you're more likely to get side effects. So pay attention to the inhibitor question. That is the one that is more likely to show up. Here's an example of an inhibitor. If I'm on a macrolide and I'm taking the drug theophylline, now who's a patient that might be taking these two drugs at the same time? Perhaps a patient with chronic bronchitis. If you think about strategies for chronic bronchitis, bronchodilators are very popular. And while theophylline is not one of our most popular bronchodilators anymore, it does make for a good test question. So what if that person is on theophylline? Why would I put them on a macrolide? Because patients with chronic bronchitis have a lot of mucus production, and mucus production in the lungs, great environment for respiratory tract infections, and macrolides are an excellent group of drugs to treat those types of infections. So if I put this patient on a macrolide and they're taking theophylline, the plasma levels of theophylline are going to be elevated compared to somebody who's only taken theophylline, but not a macrolide. That means a greater risk of side effects from theophylline. This is a drug which raises cyclic AMP levels. When that happens in the heart, you can get arrhythmias. And so that's how that patient may present, with arrhythmias based on starting them on a new antibiotic that raise the plasma levels of that drug. Now we're making one big assumption here. And our assumption is that metabolism inactivates the drug. If metabolism is converting theophylline from its active form to its inactive form, then a P450 inducer is going to lower its plasma levels, and a P450 inhibitor is going to raise its plasma levels. And that's the assumption that you should follow. When we come across some drugs that are prodrugs, keep in mind the opposite is going to be true. If it's a prodrug, the inducer is going to convert it to its active form more readily, and the inhibitor is going to prevent it from forming its active form. So that's a different scenario, but that is much more rare than what we're assuming here. If you look at the table listing all of the different drugs and all the different P450 enzymes there, down at the very bottom, you see a listing of P450 inducers and P450 inhibitors. Of course, there's a lot of inducers and a lot of inhibitors, but I want to give you a way to remember some of the most important drugs, the ones that are most likely to show up on your exam, and then let's talk about the possible drug interactions. First, for the inducers. If you come up with a phrase, and the phrase for me starts with smoking and drinking, sounds like we're having a good time, doesn't it? Smoking and drinking, because cigarette smoke has hydrocarbons, which are P450 inducers. Drinking, because chronic ethanol is a P450 inducer. Now, where are we going to do our smoking and drinking? That's right, in Barb's car. So who is Barb? Barb is a barbiturate like phenobarbital. Phenobarbital is a classic inducer. Car, carbamazepine, one of our anticonvulsants, very popular drug. Notice smoking and drinking in Barb's car riffs her fin. Now, rifampin. Maybe my favorite inducer for your exam is rifampin, a popular antibiotic, anti-tuberculosis type drug, and then phenytoin an anticonvulsant. So those are my inducers. The hydrocarbons from cigarette smoke, chronic ethanol, barbiturates like phenobarbital, carbamazepine, rifampin, and phenytoin. Again, the inducer question is less popular on the test, only because the inducer is going to lower the level of the substrate, making it less effective. You know, the only time an inducer question becomes really, really exciting is if the substrate happens to be an oral contraceptive. Now think about that scenario. Why is that an exciting question? Because if you're on an inducer and an oral contraceptive at the same time, the levels of the oral contraceptive are going to be decreased. So how does that scenario end? That's right, in my favorite side effect, which is pregnancy. Pregnancy because of reduced effectiveness of the oral contraceptive. Now that's an exciting inducer question, so be ready for that one. Rifampin, very popular drug to think about in that interaction, but others could be used as well in that scenario. Let's look at the inhibitors. Again, more likely to see these. I used the mnemonic Coke to remember several of these inhibitors. If you're a fan of mnemonics, I like mnemonics. I think they're great ways to remember drugs and lists of drugs, but you have to be careful because sometimes students need mnemonics to remember their mnemonics, and so it can get out of hand. But Coke, notice, can stand for cimetidine, omeprazole, ketoconazole, and erythromycin. Out of those four drugs, clearly cimetidine is my favorite, easily my favorite. Cimetidine is an over-the-counter medication. Cimetidine interacts with a lot of drugs. So it's really more important to remember that one perhaps than the others. Omeprazole, also available over-the-counter, doesn't interact with as many drugs as cimetidine does. Ketoconazole is a possibility to show up on your exam as an inhibitor, though its use has really significantly declined in recent years. And erythromycin, one of our very important macrolides, certainly could show up on the test as well. If I had to pick two out of that list, cimetidine and erythromycin, watch out for those two on the exam. But what am I going to do with my Coke? Well, I'm going to mix it with grapefruit juice. Doesn't that sound like a good idea? Coke and grapefruit juice. Grapefruit juice, if you look in the note in the margin there, the clinical correlate reminds us that grapefruit juice has components that inhibit drug metabolism. And there's a list of drugs there that grapefruit juice can interact with. Perhaps the most important drug on that list is the drug atorvastatin. In fact, all of the different statin drugs that are HMG-CoA reductase inhibitors, those are very, very popular, very, very important drugs. First, start with a scenario. Why would somebody be taking a drug like atorvastatin? Because of high cholesterol, correct, high cholesterol. But what else do you recommend to that patient besides taking atorvastatin every day? You recommend that they change their diet, that they exercise more. Maybe you finally get a patient that will listen to you, and they decide, hey, I'm going to change my diet. In fact, a friend of theirs told them that grapefruit juice is very healthy, so they start drinking grapefruit juice every day with their breakfast. Tell me why that's bad for this patient. If they're on grapefruit juice has components that are P450 inhibitors. The plasma levels of your statin are going to be increased. Now, what is that patient going to complain of? Perhaps they're going to complain of muscle pain. Perhaps they're going to experience more muscle soreness because of high levels of the statin in the plasma caused by grapefruit juice. You know, it doesn't happen just from drinking the juice. You can eat grapefruits. If you eat grapefruit, you still get the components that can affect drug metabolism. So eating or drinking grapefruit, again, that can be a problem. Make sure you don't get grapefruit and grape mixed up. If the question says grape juice, first of all, that's kind of evil, don't you think? If it gives you both grapefruit juice and grape juice as choices, always pick grapefruit. That's the P450 inhibitor. But eating grapes versus eating grapefruit, it's grapefruit that you have to pick there. So I've got Coke and grapefruit juice. So I've got my drink. I need something to eat. So Coke and grapefruit juice with your pie. Now, PI, what does that stand for? Protease inhibitor. Protease inhibitors used for HIV because all protease inhibitors are P450 inhibitors. Examples of the protease inhibitors, drugs like ritonavir or indinavir. Those drugs that end in AVIR are protease inhibitors used for HIV, and they're all P450 inhibitors. Finally, a note about macrolides. Here's maybe a neat way to remember the macrolides and their effect on P450 enzymes. The three most popular macrolides, azithromycin, clarithromycin, and erythromycin. If you'll take the first letter of each drug name and put them in alphabetical order, you form ACE. What you've just done is you've listed your macrolides in order of the least to the most P450 inhibitor effect. In other words, azithromycin has the least P450 effects. In fact, it's the most popular macrolide. It's the most commonly prescribed of these drugs. It has no drug interactions. The macrolide with the most drug interactions is erythromycin. Watch out for that one, but don't forget that clarithromycin is also a P450 inhibitor. So you've got to watch out for the interaction between clarithro or erythromycin with other drugs. Other phase 1 reactions that don't involve P450 enzymes include hydrolysis reactions, where you're adding a water molecule to break bonds within those drugs. Examples, esterases, amidases. If I think about the enzyme called pseudocholinesterase, this is an enzyme that breaks down the drug succinylcholine. In fact, my clinical vignette reminds us that if you have a deficiency in pseudocholinesterase, then you're not going to be able to effectively break down succinylcholine, so you get higher levels of this drug. We'll talk about that in more detail in section 4, but this is a type of genetic polymorphism that can result in higher levels of succinylcholine. You also have monoamine oxidases, enzymes that metabolize endogenous neurotransmitters like norepinephrine and serotonin. These same enzymes metabolize exogenous compounds like tyramine. Tyramine is found in things like beer, red wine, cheese, and certain types of fish. We're going to focus a lot on tyramine later on in possible drug interactions, but for now, remember, tyramine is metabolized by monoamine oxidase. Alcohols are also metabolized, and there can be some genetic polymorphisms related to the enzymes in alcohol metabolism, which is why some individuals are more sensitive to drinking alcohol than others. They can't metabolize the alcohol as effectively. The other type of metabolism reactions are called phase 2. Phase 2 reactions are also referred to as conjugation reactions. And the word conjugation basically means that you're going to attach a molecule to the drug. Take the first example here of glucuronidation. I mean, what does it sound like? Glucuronidation, it kind of sounds like glucose. So you're going to take a glucose-like molecule and attach it to the drug, or you're going to conjugate it with the drug, and that's the idea. But in order to attach a molecule, a glucose-like molecule in this case, to the drug, you need an enzyme. And those enzymes are transferases. So make this connection. All phase 2 reactions involve transferase enzymes. So what's the enzyme that accomplishes glucuronidation? It's the enzyme glucuronyl transferase. You need to transfer that glucuronide conjugate. There's a couple of clinical vignettes that I want to go over here that are related to glucuronidation. The first one is the drug chloramphenicol and its toxicity. If I said, what does chloramphenicol do to neonates? Everybody should identify that that drug can cause gray baby syndrome. But of course, that's the what question. What does chloramphenicol do to neonates? Gray baby syndrome. What about the why question? Why does chloramphenicol cause that effect? It's because chloramphenicol is metabolized by glucuronidation. And if you look at the bottom of the slide, it tells you that neonates have reduced activity. In fact, neonates have low levels of the enzyme glucuronidyltransferase, and so they can't metabolize chloramphenicol. The only time that you're going to have this type of an effect from chloramphenicol is when the levels of this drug really accumulate in the body. That happens in neonates because of an inability to metabolize the drug, and it shows up as this ashen gray appearance that we call gray baby syndrome. The second clinical vignette is a deficiency in this enzyme, known as UGT1A1. The GT is the glucuronidyltransferase. If you're deficient in this enzyme, you might get syndromes like Gilbert syndrome or Crigler-Najjar. These are syndromes that you would have covered in pathology, but help us to remember that glucuronidyltransferase is the enzyme that's deficient. Bilirubin, of course, is cleared by glucuronidation. So if you can't metabolize the bilirubin, you get an increase in the levels of unconjugated bilirubin. The third clinical vignette is a way to distinguish Crigler-Najjar type 1 from type 2. We can actually use the drug phenobarbital for this purpose. Phenobarbital can be used because not only is it an inducer of P450 enzymes, it's also an inducer of glucuronidation. Phenobarbital can increase the levels of glucuronidyltransferase. Notice, that would be beneficial for a patient with Crigler-Najjar type 2 because they just have a partial deficiency in this enzyme. But phenobarbital would not be helpful for a patient with type 1 because they have an absolute deficiency in glucuronidyltransferase. So a response to phenobarbital tells you that it's type 2, and the lack of response indicates that it's type 1. Other types of phase 2 reactions include acetylation. The issue with acetylation that is very, very popular on step 1 is that you can get genotypic variations in the population. There are fast acetylators and slow acetylators. Some people metabolize this drug very rapidly. We'll call those people fast acetylators, whereas others are going to be much slower to metabolize drugs by acetylation. The side effect that you've got to watch out for is drug-induced lupus. Drug-induced lupus happens in slow acetylators who take the drugs hydralazine, procainamide, or isoniazid. Hydralazine is the most popular test question because it's the drug that is most likely to produce drug-induced lupus. But importantly, it only happens if you're a slow acetylator. If you're slow to metabolize this drug, it's going to accumulate in the body, and that can result in drug-induced lupus. If you don't get a hydralazine question on your exam, you're probably going to get a procainamide question. This is that popular. And even though isoniazid is the drug that we discovered drug-induced lupus with, it's probably the least likely of the three to show up on the test. It's the least common in terms of occurrence of those three drugs. If you like mnemonics, you can come up with a mnemonic for the three lupus-causing drugs, and that mnemonic is HIP, H-I-P. You can come up with a phrase. You can say it's hip to have lupus. You can say HIP, H for hydralazine, I for isoniazid, and P for procainamide, the three lupus-causing drugs. You also have glutathione conjugation. We'll discuss this in more detail later on as we're covering acetaminophen hepatotoxicity. Since the drug-induced lupus question is such a popular question on step 1, you've actually got to be able to distinguish drug-induced lupus from non-drug-induced lupus, because these are going to have some features in common. Both drug-induced and non-drug-induced lupus, patient might experience a butterfly malar rash as shown in this diagram. Patients will have a positive ANA, anti-nuclear antibody test, comes back positive, Those are things that are not going to distinguish if it was caused by a drug or not. How do you know it was caused by a drug? Drug-induced only, you're going to see antihistone antibodies. So positive for antihistone antibodies says it's drug-induced. Perhaps the question does this. Perhaps you have a patient who's on multiple medications, and at some point they experience the symptoms of lupus. The physician decides to stop all of the patient's medications and observes that the lupus goes away. That's another indication that it was drug-induced, and you're going to be asked to identify what was the cause. Look back at the list of medications, identify one of those 3 lupus-causing drugs, probably hydralazine, as the cause of their drug-induced lupus. Part 4 of pharmacokinetics involves drug elimination. Drug elimination, there's 2 main ways that we can eliminate drugs. That would be biotransformation, in other words, liver metabolism to eliminate the metabolites, or renal excretion. The liver and the kidneys are clearly the 2 most important organs for drug elimination. They're not the only organs, but they are the 2 most important ones. When we talk about elimination, we use the term half-life. Easy to define half-life. Half-life is the time that it takes to decrease the plasma level to 50% of a former level, so we have to discuss half-lives as we're talking about drug elimination. There are 2 types of elimination. There's zero order and first order. Now, zero order is the exception to the rule. In other words, very, very few drugs are actually eliminated by zero order kinetics. When I think of zero order, make sure you highlight that it's a constant amount of drug that's being eliminated per unit time. A constant amount is the key thing. Also notice this, that drugs with zero order elimination have no half-life. They don't have a consistent half-life. Maybe another way to say that is that half-life has no meaning with zero order because it's not constant. The half-life is actually changing with zero order elimination. So you really can't use that term effectively as you describe zero order kinetics. When you think about zero order, think about these 3 drugs. They're listed at the bottom of the slide: ethanol, phenytoin, and salicylates. But when I think about salicylates, I'm pretty much going to focus on aspirin as the primary drug here. My phrase to remember those 3, take the first letter of phenytoin, ethanol, and aspirin, and you can come up with this phrase that says 0 P's for me. 0 for zero order kinetics, P's, P phenytoin, E ethanol, A aspirin, 0 P's for me. It's a way to say, hey, I don't like P's. 0 P's for me. Those are your 3 zero order kinetics drugs. But it turns out that it's not all doses of those drugs are zero order elimination. Take phenytoin, for example. It's only the high therapeutic doses of phenytoin that are going to be zero order. Lower doses of this drug are actually first order. If you look at aspirin, it's only aspirin overdose where you get into zero order kinetics. The therapeutic doses of aspirin are all going to be first order. So you have to overdose on aspirin to get to that zero order state. Ethanol is the one of the 3. Here's the phrase that we use. We say all reasonable levels of ethanol are zero order. That's the part that always bothered me. Reasonable. I mean, what's reasonable to you may not be reasonable to me, or what's reasonable to me now is probably not the same as what was reasonable to me 20 years ago. What that really means for us is that it doesn't take much ethanol to saturate the enzymes that are involved in elimination and put it into zero order kinetics. If you look at the box on this slide that says in a nutshell, it's a reference over to page 13, kind of reminding us that zero order kinetics is going to happen when you saturate elimination mechanisms. Most doses of ethanol can do that. Only the high doses of phenytoin can do that, and only the toxic doses of aspirin can saturate those elimination mechanisms, which means your enzymes involved in elimination are working at Vmax. It's always great to have an example of zero order elimination. If you look at this slide and you start with 80 milligrams of a drug, after 4 hours, we're down to 70 milligrams. 4 hours later, we're down to 60. 4 hours later, we're at 50. And then 4 more hours, we're down to 40 milligrams. Check the amount. How much drug did we lose in the first 4 hours? We lost 10 milligrams. How much in the second 4 hours? Also 10 milligrams. In the third 4 hours, 10 milligrams. And in the fourth period of time, we lost 10 milligrams. We are losing a constant amount per unit time. We're losing 10 milligrams every 4 hours. So if I'm ever given numbers like this, very easy to tell if I'm dealing with first order or zero order. I simply look at the amount that I'm losing per unit time. You might also see zero order kinetics represented graphically. When we look at the graph on the left, we're plotting time versus units of drug on a linear scale. Both time and units of drug are plotted on a linear scale, and I get this type of linear decay. The graph on the left is probably the one that you're more familiar with, whereas the graph on the right, which plots time on a linear scale versus the log units of drug, this is a semi-log plot. This one is probably not as familiar to you. You get this type of curve here showing elimination involving zero order kinetics. So probably more likely to see the graph on the left, but be aware that there are different ways that we can plot zero order kinetics. With first order elimination, it's not a constant amount of drug, it's a constant fraction of drug that's eliminated per unit time. Once again, highlight that phrase. Constant fraction is being eliminated. In fact, this is what most drugs are going to follow. Most drugs are going to be eliminated by first order kinetics. In fact, we can pretty much go with the rule that if it's not phenytoin, ethanol, or aspirin, it's going to be eliminated by first order kinetics. And in this case, we're going to follow typical enzyme kinetics. And what I mean by that is we're not saturating the enzymes. If zero order is really saturation kinetics, then first order is non-saturation kinetics. The enzymes are working at less than Vmax. Only in first order can we use the term half-life, because half-life is a constant in first order elimination. Once again, it's good to have an example. Here for first order elimination, we start with 80 milligrams, but we're actually told that the half-life of this drug is 4 hours. So every 4 hours in this graph, we're seeing the levels be cut in half. We go from 80 down to 40 in 4 hours, 40 to 20 in 4 hours, 20 to 10 in 4 hours, and then 10 down to 5 milligrams in 4 hours. But let's check the amount. How much drug is lost in that first 4-hour period? It was 40 milligrams. In the second 4-hour period, it was 20 milligrams. In the third period, it was 10 milligrams. And in the fourth period, it was 5 milligrams. The amount is changing. It can't be zero order kinetics. This is first order. The amount is varying, but the rate is the same. You're seeing a constant fraction, which is the drug levels are being cut in half each time period. There are two ways to check what type of kinetics that you're dealing with. Number one, check the amount. If it's constant, if it's the same amount, that's zero order kinetics. If the amount is changing, it's first order. The second way is to check and see if you have a consistent half-life. Here, we have a consistent half-life. Every 4 hours, the levels are being cut in half. At the bottom of my slide, I've got a couple of practical ways for you to use the concept of half-life. Practical as opposed to, say, doing a mathematical calculation for half-life. The first example says, what if a patient is dosed with 80 milligrams as shown in this diagram? Can you answer how much drug is left after 4 half-lives? It's a fairly easy question, simply asking you to decay the drug 4 times. The first decay goes down to 40, the second to 20, the third to 10, and the fourth takes you to 5 milligrams. After 4 half-lives, you have 5 milligrams left. What if we went the other way? What if you have a patient that shows up at the ER and you measure and find that they have 5 milligrams of drug in their body? The patient said she dosed 8 hours ago. How much drug did she ingest? Well, if she's got 5 milligrams now, I have to back up 8 hours, which is 2 half-lives. So I'm going to have to double that amount twice. The first 4-hour period, if you go backwards, 5 goes back to 10. The second 4-hour period, 10 goes to 20 milligrams. She ingested 20. That would be the correct answer to that question. You can also look at the graphs for first-order kinetics. Again, I think the graph on the left is the one that most people are familiar with. It plots time versus units of drug, both on a linear scale. And you get this type of exponential decay for first-order kinetics. Here's the scary thing. Look at the graph on the right. If I plot time versus the log units of the drug, notice how I get this linear decay that reminds me of zero-order kinetics, plotted on a linear scale. So the similarity between those two graphs is a point of concern, no doubt. It means really a couple of things. One, it means you might have to pay attention to your axes. Is it units of drug or is it log units of drug? The second is, how about if there's another way to distinguish what type of kinetics I'm dealing with when I look at a graph? That other way would be to determine half-life of the drug. We're going to do that on the next slide. So in this graph, we're plotting time versus plasma levels of the drug. In this type of graph, we can actually estimate half-life. And if I can estimate half-life and get a consistent half-life, I know that I'm dealing with first-order kinetics. I know that that's what I'm dealing with. You should notice by the shape of this curve that it's an IV dose. Do you notice that the plasma levels start up high and then follow with the elimination phase over time? In fact, when you look at the graph and you carefully analyze, there actually are two slopes shown here. The first slope is the distribution phase. It's very short. Time-wise, it happens very quickly. That first slope represents the drug being distributed from the plasma into the tissues. The second line, the second slope, is much longer and represents the elimination phase. Here's a rule for you to follow. If you're ever going to try to estimate the half-life of a drug from a graph like this, you always want to look at the elimination phase in order to do your estimation. Choose plasma levels that will correspond to a portion of the elimination phase. Never use those higher plasma levels that correspond to the distribution phase. So to estimate half-life, first I'm going to pick a number. Let's say I pick a plasma level of 4. I follow 4 over until it intersects with my line. I come down to the x-axis and I read 3 hours. I make a mark right there. The question really is, how long does it take to go from a plasma level of 4 to a plasma level of 2? Let's follow 2 over to the line. When I follow 2 all the way across to where it intersects with my graph, and then I come down to the x-axis, I make a mark at 6 hours. The difference between those two lines, from 3 to 6, is 3 hours, and that is an approximation of the half-life of the drug. So once again, I can use a graph to estimate half-life. And if I wanted to, I could repeat that and find out if I get a consistent half-life. If I do, that's first-order kinetics. If I don't get a consistent half-life, that would be zero-order kinetics. When it comes to renal elimination, the rate of elimination is a function of GFR plus how much of the drug was actively secreted minus how much of the drug was reabsorbed, either actively or passively. So GFR plus secretion minus reabsorption. When you think about renal filtration is a non-saturable linear function. We've learned earlier that both ionized and non-ionized drugs can be filtered, but protein-bound drugs cannot. Clearance is constant in first-order kinetics. In fact, clearance is equal to GFR when you don't have reabsorption or secretion, as well as no plasma protein binding. It doesn't really sound realistic, though, because many drugs are bound to plasma proteins. So I have to think about clearance being a function of the free fraction of the drug. In fact, it's the free fraction multiplied times the GFR that will estimate the clearance of the drug. But free fraction is not something that is commonly given to you in a question. What are they more likely to give you in a test question? They will give you how much of the drug is bound to plasma proteins. So simply take 100% minus the percent bound to give you the free fraction. If a drug is 80% bound, then 20% of it is free. 20% times my GFR gives me the clearance of that drug. Once again, only the free portion of that drug is being filtered and cleared from the body. But let's do some interpretation here. It's very important for you to actually see numbers and explain what those numbers mean. What if you're told that the actual clearance of a drug is less than GFR? The clearance is less than GFR. You have to assume that what process is going on. If the clearance is less than GFR, then I must be reabsorbing that drug. I filtered a certain amount, but that's not what I'm eliminating. I'm eliminating less than that. So I must be reabsorbing the drug. On the other hand, if the actual clearance of a drug is greater than the GFR, then I must be adding to the filtrate. I must be actively secreting that drug into the renal tubules, because what I filtered is not as much as what's being cleared, so I must be adding to the filtrate at that point. I'm Dr. Stephen Harris, Professor of Pharmacology and Physiology and Associate Dean for Academic Affairs at the Kentucky College of Osteopathic Medicine. I will be teaching pharmacology, and our Pharmacology Section 1 lectures begin with general principles. Chapter 1 is going to deal with pharmacokinetics. This diagram shows us the relationship between pharmacokinetics and pharmacodynamics. These are terms that you need to be familiar with, and the first thing that you should do is you should come up with a definition for each of these terms. I believe in simple definitions, so let's come up with a simple definition for pharmacokinetics. Pharmacokinetics is what the body does to the drug. So remember, what the body does to the drug is pharmacokinetics. On the other hand, pharmacodynamics is what the drug does to the body. Obviously, these two terms are interrelated. When we look at this diagram, what I would challenge you to do is to look at which parts of this figure represent pharmacokinetics and which part represent pharmacodynamics. We can administer drugs, and there are a lot of different ways to do that. Drugs get absorbed into the plasma. They can be distributed to tissues. Sometimes they can be bound up in the plasma, or they can be bound up in tissue storage sites. Drugs are metabolized. We know the liver is the main organ for drug metabolism, but it's not the only organ. Other organs can contribute, of course, to drug metabolism. And drugs are excreted, where the kidneys are the primary organ, but once again, not the only organ. If you stop and reflect on those four things, absorption, distribution, metabolism, and excretion, those are all things that the body is doing to the drug. So those are our four parts of pharmacokinetics: absorption, distribution, metabolism, and excretion. I will tell you that on your Step 1 exam, very, very few questions will deal strictly with pharmacokinetics. That means more often than not, questions on your Step 1 exam are going to deal with pharmacodynamics. The part of this diagram that deals with pharmacodynamics is shown on the right side here, where the drug interacts with its receptor. And the two most popular pharmacodynamics questions are mechanism of action and side effects. Mechanisms of drugs are tested heavily on Step 1 exam. They're tested a little bit less on Step 2 and Step 3, but side effects get tested really across the steps. So when I look at this picture, remember the relationship between kinetics and dynamics. First, we're going to talk about the concept of drug permeation. When you think about permeation, permeation is really the ability of a drug to move effectively in the body. There are certain factors that are really, really important for determining drug movement. The two most important of these are lipid solubility and concentration gradient. Lipid solubility, most drugs are designed to be lipid soluble so that they can move easily within the body. And concentration gradient, because most drugs are going to move passively down their concentration gradient. So these two factors are really the most important determinants of drug movement. But other factors can contribute, things like surface area and vascularity. If you take surface area, for example, if you imagine taking a drug orally, you compare the absorption of that drug from the stomach versus the small intestine. And if you think based solely on surface area, the small intestine, of course, has a much larger surface area. So if you're thinking of surface area, the small intestine is where drugs are more likely to be absorbed compared to the stomach. When it comes to vascularity, if you think about different types of administrations, an intramuscular injection compared to a subcutaneous injection, for example, the intramuscular injection is obviously going to be absorbed faster into the body because muscles are more vascular compared to fat. So the subcutaneous route is going to be a slower route compared to IM. Our next topic is ionization. Ionization is very, very critical for you to understand for your Step 1 exam. When you think about the topic or the concept of ionization, you have to remember that most drugs are weak acids or weak bases. Probably at least 80% of all drugs fall into this category. And what that means is that drugs can exist in two forms. They can either be non-ionized or they can be ionized. You should remember that the non-ionized form of the drug, that is the uncharged form of the drug, whereas the ionized form is the charged form. And predicting how much of each form is going to exist depends on knowing two other things, and that is the pH of the environment and the drug's pKa. You don't have to worry about remembering specific pKa's for drugs. If the exam wants you to do anything with pKa, they will tell you what the pKa is for a particular drug. You probably should be familiar with certain pHs. We'll discuss that on a later slide. Remember that the concept of pKa is defined as the pH at which the molecule is 50% ionized and 50% non-ionized. It's also important to remember that only the non-ionized form of the drug, the uncharged form, is the only form that really can effectively cross membranes. On the other hand, the ionized form is really more likely to be renally excreted because ionized drugs can't cross membranes effectively. They're more likely to be eliminated. If you look in the margin, there's a note called "in a nutshell." It reminds us about those weak acids and weak bases. It reminds us that the ionized form is water-soluble. That's why it's more readily eliminated. The non-ionized form is more lipid-soluble. That's why it easily crosses membranes. That's why that's the form that's going to stay in the body longer. The notes that I have at the bottom of this slide talk about some very important weak acids and weak bases. These are drugs that I will discuss along the way during the lectures. Some of these are going to be drugs that you already remember what type of drug they are. If I look at the list of weak acids, for example, don't you already see one of these drugs that you recognize? The first drug there, aspirin. Acetyl salicylic acid. Most people already remember that that drug is a weak acid, but it's also important to remember that loops and thiazides, very, very popular diuretics, are also weak acids. When it comes to weak bases, local anesthetics are weak bases. I think there's a mechanism of action question waiting for you on Step 1 related to local anesthetics. I'll say it this way. In order to describe the mechanism of action of a local anesthetic, you have to understand the concept of ionization, so watch out for those. Then I also notice amphetamines and PCP. PCP, phencyclidine. PCP, also known as angel dust, both of those drugs, PCP and amphetamines, are drugs that potentially can be abused. So knowing that they're weak bases gives you an advantage on the exam, perhaps as it relates to being able to eliminate those drugs. In order to effectively describe the concept of ionization, this slide is critical. When I look at the relationship between a weak acid and a weak base and the different forms that are going to exist, first start with the weak acid. Notice the two forms of the weak acid. On the left, you see RCOOH. Basically, that would be a carboxyl group with a hydrogen attached to it. Notice that that form has no charge, therefore you would call it non-ionized, and that's the form that will easily cross membranes. On the right side, we see RCOO-. We see a negatively charged molecule. That, of course, is the ionized form. It's water-soluble, and that form of the drug is going to be better cleared. Now, the next thing that I'm going to say depends on how comfortable you are with your chemistry. If you love chemistry, if you love talking about carboxyl groups, then that's fine. On the other hand, I actually strongly suggest that you simply remember an easier way to diagram out what's going on with a weak acid. On the left, I would write this as HA. So the H, of course, stands for the hydrogen, and the A could be your acid drug. So HA would be an acid drug with a hydrogen attached to it. Notice that form has no charge. That is your non-ionized form. And on the right, instead of writing a carboxyl group with a negative charge, how about just thinking of it as an A, an acid drug with a negative charge, and the hydrogen has been removed. You can do the same thing with a weak base. On the left side of the diagram, you could go with RNH3+, a positively charged base. That's the ionized form that's better cleared. Another way to write that would be to write BH+. Again, B for base with a hydrogen attached to it has a positive charge, so it's ionized. On the right side, RNH2 would be your non-ionized base. You could also write that as B, simply the letter B for base, again with the hydrogen removed. Now you have to write these in the order as they're written. On the left side, you have to write the drug with a hydrogen attached to it. And on the right side of the diagram, you have to write it with the hydrogen being removed. This is very critical to your understanding of this concept, because I want you to think about this, that if I were to draw a line right down the middle of this diagram, right through the arrows, that really could represent the drug's pKa. What I'm saying is, if the pKa is right in the middle of this diagram, when I put an acid or a base into a pH that's lower than the drug's pKa, those drugs are going to have hydrogens attached to them. So if it's an acid, it's going to be HA. If it's a base, it's going to be BH+ at lower pHs. Because what do you find at low pHs? You find lots of hydrogens. On the other hand, the right side of the diagram would represent pHs that are above the drug's pKa. When you get greater than the drug's pKa, the pH, you're going to see that the hydrogens are removed. The hydrogens get removed from the acid or the base, leaving you with either A- or B. So the left side of the diagram becomes more acidic. The right side of the diagram is more basic or alkaline in relation to the drug's pKa. A final note on this slide. The term protonated is sometimes used in test questions. Obviously, a hydrogen is a proton. If I say, what does a protonated acid look like? A protonated acid is going to be on the left side of my picture here, HA. A deprotonated acid, A-. A protonated base, BH+. A deprotonated base would be B, the non-ionized form. So you have to really draw this diagram out. Think about it in order to answer these questions and not mess up this concept, because you can sometimes try to do this too fast. If I say, is a deprotonated acid going to effectively cross membranes? You have to think to yourself, a deprotonated acid is A-. That's ionized. That form will not effectively cross membranes. That form will be better cleared from the body. So be very careful with this concept. So here's our first graph. I would tell you that this might be the most challenging graph that we have to deal with in all of pharmacology. So that's very exciting that we get to deal with this here in the very first chapter of section 1. It's a graph that has an x-axis and 2 y-axes. So that makes it challenging from the start. You've got 2 y-axes here. In fact, if you look at the x-axis actually has a calculation on it. That's exciting as well. So some of you are thinking, I'll just skip this one and move on to the next graph. So if you're graphophobic, let me make sure that you understand. Always look at what your axes are showing you. The x-axis here shows us pH minus pKa. Two terms that I think we have to know anyway. Two numbers that they're probably going to give you in a test question, but two numbers I'm sure that you can work with. For example, if I do a calculation of pH minus pKa and I get a negative number, what does that mean? If I get a negative number, by the way, never live in abstract land. Always come up with a concrete example. So pick a pH, let's say a pH of 4 and a pKa of 6. If I did 4 minus 6 and I get negative 2, what does that mean? Obviously it means that the pH was lower than the drug's pKa. So the left side of my x-axis is going to be the acidic side, where the pHs are lower than the drug's pKa. The right side of my x-axis, if I did a calculation, let's say the pH was 7 and the drug's pKa was 5. If I do 7 minus 5 and I get a positive 2, that means the pH is greater than the drug's pKa. So the right side of my x-axis is a basic environment. Once again, those terms, acidic and basic, are relevant to the drug's pKa. That's what our reference point is. It's acidic or basic in relation to the drug's pKa. The graph shows you two lines, one for a weak acid and one for a weak base. You should be able to predict What form of the weak acid is going to exist in an acidic versus a basic environment? So if I start at the top left of this graph, if I put a weak acid into an acidic environment have lots of hydrogens, so I'm going to have a hydrogen attached to the drug. It's going to be in the HA form. The major form of the weak acid, the lower the pH, in fact, the more HA I'm going to have. But what is happening as I move left to right on this graph? If you follow your x-axis from the left side over to the right, what is changing in the graph? It's not the drug's pKa because that's a constant. What's changing is the pH is going up. So what is going to happen as the pH goes up? As I get a higher and higher pH, more of the hydrogens start to be removed from the drugs. So the HA form is going to start turning into the A- form. The far right side of my graph, where I've got a much higher pH, hydrogens have been removed, and the drug is primarily going to be A-. So I go from a state on the far left, where I'm highly non-ionized, HA, to on the far right, where I'm highly ionized because the pH has gone up and the hydrogens have been removed. If you look right in the center of this graph, what does it mean when pH minus pKa equals 0? Obviously that means that pH and pKa are the same, and therefore you're going to have a 50-50 relationship. 50% of the drug is ionized and 50% is non-ionized. You can do the same thing for the weak base. The bottom left corner, you put a weak base into an acidic environment. You're going to have lots of hydrogens there. The hydrogens attached to the drug, it's going to be BH+ in a low pH environment. It's highly ionized when you take a weak base and put it into a low pH, into an acidic environment. As I move left to right, we know the pH is going up. As the pH goes up, the hydrogens are removed from the weak base, turning what was a highly ionized drug now into a highly non-ionized drug on the far right side. So the weak base in the B form is going to be easily absorbed. It's highly non-ionized. If I look on the far right of the graph, on the far right I see the other y-axis that shows renal clearance of the drug. Notice that the arrow is going down. Make sure you don't miss this. The arrow is going down. So the forms of the drug that are more likely to be cleared are found at the bottom of this graph. And those forms, of course, A- and BH+, those are the ionized forms of the drug. It's the ionized forms that are more likely to be cleared from the body. At the top of the graph, the HA form and the B form are non-ionized. Those are forms that are going to stay in the body. Next, we want to look at how ionization increases the renal clearance of drugs. There are several points to remember about renal clearance. When it comes to the glomerulus, remember, only free, unbound drugs are filtered. In other words, drugs that are bound to plasma proteins are too large to be filtered at the glomerulus. Once again, you're thinking about normal renal function at this point. Watch out for the second bullet point. Both ionized and non-ionized forms of the drugs are filtered. This is the part that folks will miss. They will think about the concept that we've previously discussed, that ionized drugs don't effectively cross membranes, and that is true. But when it comes to the glomerulus is actually permeable even to ionized drugs. So hang on to that thought, and we'll see it in the diagram on the next slide. It's the non-ionized form of the drug, however, that undergoes secretion and reabsorption, because those are processes that involve crossing membranes. And once you're inside the renal tubules, all the rules apply again about ionization, which is the non-ionized form can cross the membrane, the ionized form cannot. In fact, the ionized drug is what's going to be trapped in the filtrate, and this is where, if we can manipulate the pH of the urine, we can influence drug elimination. The figure here does a very good job of explaining the points that we just covered. So when I look at the glomerulus, who's going to be filtered? Free drug, but that drug can either be ionized or non-ionized. Remember, both forms can get into the renal tubules, but once they get into the renal tubules, only the non-ionized form can now cross the membrane. Once you're in the proximal tubule, for example, I can see active secretion of a drug, but it's in the non-ionized form. If you wanted to kind of summarize what you know about the glomerulus and drug filtration, here's a way to summarize that. I would say that the glomerulus is a good size filter. It's going to discriminate based on size. In other words, a drug bound to a plasma protein, that size is too large to be filtered. So therefore, the drug has to dissociate from the plasma protein to its free form. That's what's going to get filtered. But isn't it true that the glomerulus is a poor charge filter? It really doesn't discriminate based on charge, because we see that both the ionized and the non-ionized forms will get filtered. So let's talk about how ionization can affect the renal clearance of drugs, and specifically focus on ways to manipulate the pH of the urine. Think about it. Why would I ever acidify the urine? Well, I would acidify the urine to enhance the elimination of a weak base. Somebody overdoses on a weak base. Let's come up with some examples. My clinical vignette, CV stands for clinical vignette, would be patient overdoses on either amphetamines or PCP. You remember that those are weak bases. Neither of those drugs has a specific antidote. So what's a strategy that you can use to facilitate their elimination? You could take advantage of the fact that you understand ionization. You could acidify the urine. You can take a weak base drug and you can make it ionized. You can take that base and convert it to BH+, and you'll eliminate amphetamines or PCP. You can do the same thing if somebody overdoses on aspirin. Again, aspirin, a drug that does not have a specific antidote. So what's a strategy you can use to facilitate the elimination of aspirin? You can alkalinize the urine. Once again, by raising the pH of the urine, you're going to take that weak acid drug, you're converting it into A-. A- is your ionized form. The ionized form is more readily eliminated. So urinary alkalinization. In the margin, there's a clinical correlate that tells us exactly how we could do this. How do you change urinary pH to acidify the urine? You could use a compound like ammonium chloride. NH4Cl can be used on patients who overdose on amphetamines or PCP. You can acidify the urine with NH4Cl. On the other hand, what would be something you would use in aspirin overdose? You could use sodium bicarbonate. Sodium bicarb will alkalinize the urine. You can use this strategy to facilitate the elimination of aspirin. Very, very popular question on the test. I mean, why do folks overdose on aspirin? And the answer is because they can. Because they can easily access aspirin. So aspirin overdose is such a popular thing on the test. Here's a way to apply ionization principles to that scenario. If you look in the bottom right corner of my slide, here's what I call a bacterial clinical vignette. It really doesn't have anything specifically to do with drug overdose. What it's got to do with the fact that certain bacteria can change the pH of the urine. You've learned this in micro, that organisms like Proteus and ureaplasma, those are organisms that can alkalinize the urine. If you think about the action of those bacteria, they raise the pH of the urine. And for example, if you get a patient with a UTI and the urine is alkalinized, Proteus could be a causative organism there. So we can manipulate the pH of the urine, obviously with drugs, to our benefit for a patient who has a drug overdose. But we also think about what other things like bacteria can do to the pH of the urine. So I imagine that I'm you on test day, and I get a question on ionization. What do you do? Obviously, what you can do is you can actively write something related to ionization. I'm going to show you a diagram that you can use very effectively to answer really any type of ionization question. The first thing that I want you to do is remember that normal urine pH is in a range of about 5 to 8. That's a typical normal range, 5 to 8. Then, when I get that ionization question, first thing I do is I draw a pH scale. I draw that scale 0 to 14. As I read the question, somewhere in the question it's going to mention the drug's pKa. Let's say the pKa in the question was 5. I draw a line representing 5. When I draw that line, do you see what I've done? I've divided my pH scale into two parts. The first part, the pH is all lower than the pKa. That's on the left side of the picture. The second part, pHs that are above the pKa. Those are my two compartments. Now, answer this question. If this drug was a weak acid, what form of that weak acid is primarily going to exist on the left side of this figure. If I put an acid into an acid environment, I'm going to have hydrogens attached to it, so it's going to be HA. On the right side, that's going to be your more basic environment. If I put an acid drug into a basic environment, it's going to be A-. The hydrogens are going to be removed. Just for argument's sake, what if this was a weak base? With the same pKa value, let's just go with that. If it was a weak base, then it would be BH plus on the left side. Hydrogens at the low pH environment are going to be attached to the drug. On the right side, it's going to be B, where the higher pHs, the hydrogens have been removed. So can you draw this diagram? Sure you can. You can draw this diagram and you can use this to answer questions related to ionization. Let me give you a couple of those now. For example, if a patient here is taking a weak acid drug, do you think this weak acid drug with a pKa of 5 is going to be better absorbed in the stomach or the small intestine? Based on its pKa, is it better absorbed in the stomach or the small intestine? Well, what's the major form of this drug in the stomach? It's HA. The stomach, very low pH, around 1 or 2. But in the small intestine, which has a quite a bit higher pH, the drug is more likely to be in its A- form. So which of those forms easily crosses membranes? HA. The weak acid drug is better absorbed in the stomach. What about weak bases? Forget pKa for a second. Is a weak base better absorbed in the stomach or small intestine? The answer has to be small intestine, because the small intestine has a higher pH. So there's a greater chance of having the drug in the B, in the non-ionized form. That's the form that will easily cross membrane. So a simple rule for you is this. If I want to keep the drug in the body, I put that drug in its like environment. If I want to keep an acid, I put it into an acidic environment. It will stay in the body. If I want to keep a base, I put it into a more basic environment. It will stay in the body because it easily crosses membranes. But what do I do with those drugs if I want to eliminate them? I put them in their opposite environment. How do I eliminate a weak acid? I put it into a basic environment. I want to increase urine pH. So if somebody overdoses on aspirin, what would be a goal for you to raise urine pH to? If you look at the normal range, maybe getting the pH up to around 8. The higher end of the normal range would have that drug in its ionized form and more easily eliminated. On the other hand, what if I want to get rid of a weak base? You want to get rid of amphetamines? Acidify the urine. Put it into its opposite environment. Make the urine pH closer to 5. You're going to readily eliminate that drug because it's in the BH plus form. If you look in the margin on the bottom corner of page 4, you see this clinical correlate that talks about using the drug lactulose. Now, if you remember the use of lactulose, it can be used to treat hepatic encephalopathy. If you get the question on your test, what drug is useful in treating a patient with hepatic encephalopathy? That's fantastic. Right? The what question is always easier to deal with. What drug do you use for hepatic encephalopathy? The harder question to answer is why. Why do you use lactulose to treat hepatic encephalopathy? So let me give you this clinical vignette. First of all, you have to be able to recognize the patient, because sometimes they're just not going to tell you that it's hepatic encephalopathy. Characteristics of this patient: they're going to have increase in their liver function test, they're going to have increased blood ammonia, they're going to have an enlarged abdomen, and all of that would help you to recognize, hey, that's hepatic encephalopathy. You remember that you can use the drug lactulose to treat this condition. But do you remember why? It's because lactulose is metabolized by gut bacteria into lactic acid. This is why this is related to the concept of ionization. I'm basically converting lactulose into an acid, and when I do that, I am acidifying the intestinal tract. When I acidify the gut, what's going to happen is I'm going to convert ammonia into ammonium. NH3 becomes NH4+, positively charged. I'm going to add a hydrogen because, again, low pH environment, hydrogens are readily available. When I convert ammonia into ammonium, I can readily eliminate ammonium, and that's the way to lower blood ammonia. That's the rationale behind using lactulose as a treatment for hepatic encephalopathy. When you couple that with the fact that it's also a laxative, it's going to increase GI motility. That can also facilitate elimination. Next, we're going to talk about drug transport across a membrane. When you look at this diagram, there are really three basic mechanisms for drug transport: passive diffusion, facilitated diffusion, and active transport. But when I look at the different columns here, the two that I want you to always link together, the carrier column and the saturable column. See, these two columns go together because a system that uses a carrier can be saturated. So what's a characteristic of passive diffusion? Passive diffusion does not need a carrier, therefore it's not saturable. And that's really critical. Obviously, it doesn't need energy either, but it's not saturable. And I think that's the first question you want to answer. When I see that question on the exam, and I'm asked to determine what type of transport is taking place for a particular drug, the first question I want to answer, is the system saturable? Because if the answer is no, I didn't saturate it, we know that it's passive diffusion. Here's what the question might do. They will give a certain concentration of the drug, and that will produce a certain amount of movement. They will increase the concentration of the drug, you'll get more movement. They increase it again, you get more movement. If they continue to do that, and you always get more movement, you are not saturating the system, therefore that is passive diffusion. On the other hand, if I increase and get movement, increase, get movement, and then I increase again and I get no further movement, what does that mean? That means the system has been saturated. Now I've got two choices. It's either facilitated diffusion or active transport, because both of those utilize a carrier and can be saturated. Now I've got to answer question number two. Does that system use energy? Because facilitated diffusion does not, active transport does. Here's what they will do in the test question. Many times they will use an inhibitor of ATP production. If I use an inhibitor of ATP production and it has no effect on drug movement, then that obviously is facilitated diffusion. I didn't need energy, I didn't need ATP. But if I use an inhibitor of ATP production and it stops drug movement, then that is a system that required ATP. You would conclude that is active transport. That's your way to determine the type of drug movement that's going on. The concept of steady state basically talks about the fact that when you administer a drug, you're hoping that you're going to get a consistent plasma level over time. In other words, your goal is to give a patient a drug, let it reach the appropriate level in the plasma, and stay there. That will be what we call a steady state, where the rate in is going to equal the rate out and the plasma level stays constant. It's also why steady state is referred to as the plateau principle. Because when you're administering a drug, if you're looking at a graph of that drug, how do you know that you've reached steady state? Easy. The curve will plateau. When the curve rises and then levels off, you have plateaued, therefore you have reached steady state in the plasma. It's really, really important to know that the time to steady state depends on one thing. It depends on the half-life of the drug. If you know half-life, you can predict time to steady state. And that is independent of any of the other variables that you might be given, like the size of the dose, how often that you're dosing. But we do have to assume that the drug is being eliminated by first-order kinetics. In other words, if you have one of those special cases of a zero-order kinetics drug, like phenytoin or ethanol or aspirin, then you really can't discuss effectively the concept of steady state, because you can't discuss the concept of half-life. You don't have a consistent half-life, so your time to steady state will be variable for those drugs. That's not where we go with the test question. We go after those first-order kinetics drugs, those that follow the rule on time to steady state being dependent upon their half-life. In your margin is a note about time to steady state. But I'm going to discuss this a little bit differently from what that note actually shows you. The most important part of that note, by the way, is the time that it takes to reach clinical steady state. Clinical steady state, in fact, is reached in 4 to 5 half-lives. And clinical steady state is different from what we call mathematical steady state. It takes a lot longer to reach mathematical steady state. Clinically, when we get around 93 to 96% of the way there, that happens in 4 to 5 half-lives, we call that clinical steady state. It's almost like, hey, we're close enough. We'll take that. You're not at 100%, but you're very, very close. I do think you need to understand a couple of basic numbers here related to time to steady state. Think about it this way. If you start at 0 and your goal is to get to 100% of steady state, the way to remember the numbers is this. Each half-life, I get halfway to my goal. So I start at 0 on my way to 100. So after the first half-life, I get halfway to my goal. After one half-life, I'm 50% of the way to steady state. Now I'm at 50% on my way to 100%. In the second half-life, I get halfway to my goal. So what's halfway between 50 and 100? That's right, 75%. Now I'm at 75 on my way to 100. What's halfway between 75 and 100? 87.5%. So 3 half-lives in, I'm 87.5% of the way to steady state. And then once we get to 4 or 5 half-lives, we will call that clinical steady state. Some people are more familiar and more comfortable with the concept of elimination than they are with the concept of time to steady state. Let me just tell you that time to steady state and elimination, they really have the same values. Let's illustrate it this way. How much drug have you eliminated after one half-life? Of course, you've eliminated 50% of the drug. But by percentage, how much drug have you eliminated after 2 half-lives? It's taking half of it and then taking half of what's left. That's 75%. Again, you can use real numbers here. You can say I start with 100 milligrams. After one half-life, I'm down to 50 milligrams. After 2 half-lives, I'm down to 25 milligrams. I've lost 75% of the drug. And if I went to 3, after 3 half-lives, 87.5% of the drug has been eliminated. And by that same logic, how long clinically does it take to eliminate a drug? It takes 4 to 5 half-lives. So the time to steady state and the time for elimination really have the same values. If you're comfortable with one, you're actually comfortable with both, and that's good news. This graph is going to plot time versus plasma drug concentration, and it's here to show us the rise to steady state. The dose in this example is 100 micrograms per mil. I'm going to give that dose at time 0. When I give that dose, notice I go up to 100, and then I'm going to wait one half-life. The half-life for this drug in this example is 4 hours. 4 hours later, after my dose of 100 micrograms per mil, I'm down to 50 micrograms per mil. And then I'm going to dose again with another 100. So I go from 50 up to 150. I wait a half-life, I go to 75. I dose again with 100, I go to 175. And I continue to do that. I dose every half-life. And because I'm doing that, I'm going to have these peaks and troughs. Eventually, notice how the graph is going to level off. It's going to plateau. On the far right side of this graph, you can see that we have reached steady state. Again, that's why we call it the plateau principle. When the curve plateaus, you have reached clinical steady state. But since we're dealing with a dosing every 4 hours, and you have these peaks and troughs, once you reach steady state, you're going to have a CSS maximum at the peak and a CSS minimum at the trough. And you're going to fluctuate between those two numbers, which in this case is 100 to 200. Every time you dose, you're going to go up to 200, wait a half-life, you go down to 100. So there's our fluctuation. I could approximate a CSS average. In fact, if I were to give this drug by constant IV infusion, that's what that would look like. It would approximate that CSS average. But I'm dosing every 4 hours, so I have peaks and troughs. I've also added to this graph. At the very top, I've put in a minimum toxic concentration, and down at the bottom, a minimum effective concentration. Earlier, we talked about MEC. That's that plasma level where the drug first has its pharmacologic effect. Doesn't it make sense that at steady state, you want your CSS minimum to always be above the MEC? Even at the trough levels there, you want the drug to be working in the body. But if there's a minimum effective, surely there's a minimum toxic concentration as well. So at the peak, the CSS max, you want that value to always be below your minimum toxic concentration. That range from minimum toxic to minimum effective is called the therapeutic window. And as a physician, your goal should be to keep the drug levels in that therapeutic window. Some drugs, of course, are going to have very narrow therapeutic windows, and that influences how we dose them. We might, in fact, have to dose the drug more often just to keep the drug within that window. I'll tell you something else that people will do. People will sometimes forget to take their medication. Maybe they've actually been faithful taking it up to a point where they've reached clinical steady state, and they're at their trough level, they're at the CSS minimum, it's time to take the drug again, but they forget, or they've run out of their prescription. So the plasma levels start to drop, and eventually those plasma levels could go below the minimum effective concentration, and the drug won't be working anymore. But maybe more scary than that is that sometimes folks will miss their dose, and they'll remember some hours later, and instead of taking one as recommended, they will double up on their dose. And perhaps now they get very close or go above that minimum toxic concentration. So the drugs out there that you've heard about that have these more narrow therapeutic windows are the same ones where we caution, take as soon as you remember after you've missed the dose, but never double up. Never double up on those medications, because those are the ones that will put you over that minimum toxic concentration. This is a very important graph to illustrate the point that the size of your dose does not influence time to steady state. We see 5 different infusion rates on this graph, ranging from 1 up to 5 milligrams per minute. In fact, these are really 5 different maintenance doses, and that's the term that I want you to be very comfortable with. If your goal is to reach steady state, you're going to use a maintenance dose to do that. The word maintenance, maintain. You're trying to maintain a steady state plasma level with a maintenance dose. But how do we know that a drug, when I'm infusing it in a case like this, how do I know that I've reached steady state? That's right, we remembered that we look for the plateau. Notice that whether it's 1, 2, 3, 4, or 5 milligrams per minute, every one of these curves levels off at the same time. They all plateau at the same time, so their time to steady state is the same. Time to steady state is independent of the size of your dose. What you'll notice, though, is that if I give a higher amount of drug, if I give 2 milligrams per minute instead of 1 milligram per minute, I will reach a higher level in the plasma. My steady state plasma concentration will be higher if I give more drug. That makes sense. The key is, but I don't reach that plasma level any faster if I give more drug. Keeping in mind, I have to focus on the plateau. That's where I'm going to call that steady state. That's where I know I've reached that steady state value. We also want to look at the effect of a loading dose. We know that it takes 4 to 5 half-lives to reach steady state. So if we're giving a drug by maintenance dose, we know that that's going to take a period of time. For some drugs with longer half-lives, that could be quite a long time. Some drugs have their half-lives being more than 12 hours. It's going to take probably a few days for certain examples to reach steady state. There are times, however, that we cannot wait that long. We might want to use what's called a loading dose. We do this to achieve plasma levels rapidly. You might think about emergency situations where you need to treat a patient very, very quickly. So we use loading doses. But most commonly, if we use a loading dose, it's just a single dose. It's just a one-time only dose. There's a note in the margin there, a clinical correlate, that reminds us that the loading dose equation can be used to calculate the amount of drug in the body at any time by knowing the volume of distribution and the plasma concentration. So we have a way to calculate this. We use it sparingly. Again, there's certain examples, like I mentioned with the emergency, where we might use the loading dose. In this graph, plotting time versus the plasma levels, we really see two different examples here. The example in the bottom, showing only a maintenance dose, is there to illustrate that it's going to take time in order to reach the minimum effective concentration. If we use the example of digoxin, a drug which has a half-life of almost 2 days, how long does it take digoxin to reach clinical steady state? Yeah, 4 to 5 half-lives means 8 to 10 days before this drug reaches those levels that we call clinical steady state. That's a long time to wait. Can you imagine? You're working in the ER, a patient comes in, and it's your job to take care of this patient, and you recognize that they have a life-threatening arrhythmia. So you go up to that patient and you say, well, I have good news and bad news for you. The good news is we're going to use the drug digoxin. It's a very effective drug for your type of arrhythmia. But the bad news is I only know how to administer this drug by maintenance dose. So let's say if we only gave this person a maintenance dose of digoxin, look at how much time we're going to waste. In the first 2 days, we don't even reach the minimum effective concentration. The second 2 days, we barely reach it. For about 5 minutes, this guy's arrhythmia goes away, but then it comes back. Then finally, after day 6 and into day 8 and day 10, we're finally starting to control the arrhythmia. Of course, the big catch to that scenario is, did the patient live that long? This is a scenario where you're much better off using a loading dose, with the sole purpose of that loading dose being to achieve high plasma levels rapidly. We want to get enough of the drug in the body to be effective. So if I look at the far left of this graph, I give a loading dose there at time 0. My levels are large enough there to go above the minimum effective concentration. In fact, a typical rule on the loading dose amount is that a loading dose is often 2 times the maintenance dose. Your goal is to approximate the CSS max. In the example that we looked at a couple of slides back, when we were giving 100 micrograms per mil, that was our maintenance dose, so our loading dose would have been 200 micrograms per mil. That would have approximated our CSS max. A loading dose is only a one-time dose typically. So in this example, we give the loading dose, but we always follow up with a maintenance dose. And together, the levels of the loading dose plus the maintenance dose keep us above the minimum effective concentration. Some of you might be thinking that we have sort of cheated the rule about time to steady state. And we've really not, because time to steady state, when you're talking about that with your different types of doses, you're really talking about using only maintenance doses to get to steady state. Here we're actually combining a loading dose and a maintenance dose, and the sole purpose there is to have enough drug in the body to be effective. This slide is often pretty scary for folks because it involves all the different pharmacokinetic calculations. First thing I would tell you to sort of calm you down is to remind you there aren't going to be very many calculations on your exam in pharmacology. In fact, number 1, the volume of distribution equation is probably the most likely equation to show up on step 1. That's the one where we covered earlier. It's pretty simple. It's got 3 variables. Volume of distribution is dose divided by C0. And if you know 2 of those, you can pretty easily calculate the third. It's very unlikely that you're going to have to calculate half-life using this equation, 0.7 times VD divided by clearance. I wouldn't say to not learn the equation, though. I would know this equation, but what I would learn about it is what the relationship is between the variables. What's the relationship between half-life and clearance, for example? And you note that it's an inverse relationship. By the way, if you think about that, you already know that. You know that if renal clearance goes down, that half-life is going to go up. The drug will last longer in the body with lower clearance. Maybe harder is to remember that half-life and volume of distribution are directly proportional. If volume of distribution goes up, half-life goes up. Now, does that make sense based on what we discussed earlier? Sure it does. If volume of distribution goes up, that means the drug is leaving the plasma, being sequestered in the tissues. And since it's sequestered in the tissues, it's not going to the organs of elimination. Therefore, its half-life is going to be increased. So maybe learn the equation for the relationship among the variables more than for actually doing a calculation. Equation number 3, infusion rate, is actually included in the maintenance dose equation. So my preference is to really learn the maintenance dose equation, and you've already covered your bases there by learning the infusion rate. So let's look at number 4 and number 5, loading dose compared to maintenance dose. We've discussed why you would use those things. Maintenance dose is what you're going to do when you dose a patient day after day after day. Loading dose is the one-time dose that you'll do in more rare situations, again, perhaps in emergency situations. First thing is to compare the two equations. What do they have in common? Both involve a plasma concentration. CP for loading dose, CSS for maintenance dose. We use CP for loading dose because you're really just looking at a target level in the plasma. You're not trying to get to and maintain steady state like you are with a maintenance dose. But both equations use a plasma concentration. Both equations also have F. Remember, F is bioavailability. If we give the drug IV, that's great news for you because F is 1. That makes the math a little bit simpler. Now, let's focus on the differences. Do you notice how maintenance dose involves renal clearance and loading dose volume of distribution? I like to think about it this way. If I'm going to dose somebody day after day after day with a maintenance dose, I need to know renal function. I want to know clearance if I'm going to dose them day after day. If I'm going to give them a loading dose, however, a single dose, I'm not as concerned about clearance as I am where does the drug distribute. So volume of distribution is more important for me to include in my loading dose calculation. Make sure you pay attention to differences in the way we use those two variables. The maintenance dose equation also uses the variable tau. Now tau is your dosing interval. That's going to be how often you give the drug. Is it once a day? Is it 4 times a day? That's what tau is in your maintenance dose. We don't need that variable in the loading dose. Once again, most often we're just going to give that as a single dose anyway. Now that we've finished Chapter 1, let's do a few practice questions to apply the concepts that we've covered. You can pause the video now and review the question. I'll come back and discuss in just a moment. In this question, we've got a 43-year-old man. It's really important to notice that he has a 7-year history of chronic renal disease. And that's really the key. We notice that we have a patient with chronic renal disease. He started on the drug levofloxacin. And really what we want to know in this question is how is the dosing of this drug going to be different in a patient with chronic renal disease compared to an otherwise healthy patient. Of course, chronic renal disease is going to affect the clearance of the drug. Since clearance is not a part of the loading dose equation, you would expect the loading dose to be the same. Clearance is, however, a part of the maintenance dose equation. Since you're going to have reduced clearance, you're going to have a longer half-life of the drug, we need to lower the dose of his maintenance dose. The correct answer here is choice E. Same loading dose, but lower maintenance dose. Here's our second question. Once again, pause the video, review the question, then we'll review the strategies to solve. So here we've got a series of experiments that are performed to figure out how this drug is going to move within the body. A couple of clues in this question. Notice the statement that says when the extracellular concentration of the agent exceeds 10 millimolar, no further increase in the rate of uptake is observed. That's a very important component to this question. What that tells us is that when we go above 10 millimolar, we are saturating the system. Since the system has been saturated, that rules out one of our very common answer choices here, which is simple passive diffusion. Since it's saturated, this system involves a carrier. It leaves us really with two options, facilitated diffusion and active transport. The second part of this question addresses an inhibitor of sodium potassium ATPase. When we stop ATP production, notice that it fails to inhibit the transport of this drug. That means the system in this case doesn't involve energy, so it's not active transport. That means you've decided it's saturable and it does not involve energy. Of course, the correct answer here, choice B, facilitated diffusion. Here's our next question. Once again, pause the video, review the question, and then we will discuss. So we've got a 13-year-old girl. She's brought to the emergency department by her father. It seems like this girl has taken a lot of the antihistamine diphenhydramine. We've got some information that shows the diphenhydramine concentrations measured hourly for 6 hours. The question wants to know how long after the first measurement is it going to take for the patient's plasma concentration to drop below 10. To solve this problem, the first thing that you do is determine the half-life of the drug. At 1 o'clock, the plasma concentration is 240 nanograms per mil. 4 hours later, at 5 o'clock, that level has been cut in half. We've gone from 240 down to 120. So we're going to presume that that is the half-life of this drug, which is 4 hours. You assume that because the drug is diphenhydramine. Diphenhydramine is not one of our zero-order kinetics drugs, so we're assuming that we're still dealing with first-order kinetics, and we can determine a consistent half-life. So given that the half-life of the drug is 4 hours, how long is it going to take to drop below 10 nanograms per mil? Calculate the number of half-lives that are going to be required to go below 10. The first half-life takes you from 240 down to 120. The second half-life, 120, goes down to 60. In the third half-life, we go from 60 down to 30, cut that in half. In the fourth half-life, we go from 30 down to 15, but we're still not below 10, so we have to go to a fifth half-life in order to go below 10. The fifth half-life takes us from 15 down to 7.5, so it's going to take us 5 half-lives to drop below 10 nanograms per mil. It's 5 half-lives times 4 hours per half-life. 5 times 4 is 20. Choice D is the correct answer. Chapter 2 is going to deal with pharmacodynamics. We start with some basic definitions. When you think about the terms agonist and antagonist, it should be very easy terms for you to define. An agonist basically is a drug that's going to stimulate its receptor, causing a response, whereas an antagonist binds to the receptor, blocks the action of an agonist. The antagonist by itself is not associated with a response. It simply blocks the action of an agonist. We're going to talk about an example in autonomic nervous system of receptors that actually don't have a physiologic agonist. The action of blocking those receptors, if there is no agonist, an antagonist is going to have no effect. There are 3 terms that you need to be familiar with because they might show up on a dose-response curve. You might be asked to compare affinity, potency, and efficacy of 2 or more drugs on a dose-response curve. Let's make sure we can do that. First, if I'm asked to compare affinities, affinity on a dose-response curve is measured by the proximity of the curve to the y-axis. In other words, the curve that is shifted closest to the y-axis represents the drug that has the greatest affinity. We have one big assumption here, and the assumption is the curves have to be parallel. In other words, the only way to compare affinities is if the slopes of the curves of these drugs you're comparing are parallel, and we'll see some examples of that. Potency on a dose-response curve is very similar to affinity. It's also the proximity of the curve to the y-axis, but in the case of potency, the curves don't have to be parallel. The slopes of those curves can be non-parallel, and you can still compare their potency. Finally, efficacy. Efficacy might be the easiest of these 3 terms to compare. Efficacy is the effectiveness of a drug, and that's shown by the maximum height. In order to compare efficacy for a couple of drugs, look for the curve that is the tallest. The tallest curve would be the drug with the greatest efficacy. So these are our dose-response curves, where we're going to compare affinity potency, and efficacy. Let's take the curve on the left and compare drug A to drug B. The first term I want you to compare is affinity. In order to compare affinity, you have to look at the slopes for drug A and drug B. Notice how the slopes are parallel. Since the slopes for A and B are parallel, what that means is those two drugs work on the same receptor. If and only if the drugs work on the same receptor, can you compare affinity. So the slopes have to be parallel. What do you say? You say since A is shifted closer to the y-axis, drug A has greater affinity for its receptor compared to drug B. When you think about potency, it doesn't matter if the slopes are parallel. You just simply look for the curve shifted most to the left. Curve A is closer to the y-axis. That indicates that drug A also has a greater potency than drug B. So to summarize those things, greater affinity and greater potency for drug A compared to drug B. Notice though that the curves reach the same height. Drug A and drug B both reach 100% response. That means they have equal efficacy. They are the same when it comes to their effectiveness. Now let's look at curves for X and Y. Notice how, if we start with affinity, notice how the slopes are not parallel for drug X and drug Y. Since the slopes are not parallel, you should conclude that drug X and drug Y work on different receptors. Since they work on different receptors, you cannot compare their affinities. Affinity is a term that you can only use when you're talking about a single receptor with multiple drugs. When I look at drug X and compare its potency to drug Y, the curve for X is shifted closer to the y-axis, so drug X has greater potency compared to drug Y. Notice also that drug X, the curve reaches a greater height. Drug X goes all the way to 100% response. Drug Y falls well short of 100%. So you would say that not only does drug X have greater potency, it also has greater efficacy. Now we're going to explore the concept of full and partial agonist. We use the term full agonist to describe an agonist that reaches its maximum response. If you're plotting it on a percent scale like you see in this graph, if the agonist curve reaches 100%, as we see with drug B would be a full agonist. If I told you that curve A and curve C also represent agonists, you would have to describe those as partial agonist. Partial meaning their maximum response is less than 100%. And we see that for both curve A and curve C. We're really just comparing efficacies here. So curve B has a greater efficacy compared to drug A and drug C. In case you're thinking that a partial agonist is really an ineffective drug or a drug that would be kind of useless, that's not really true. Because if you look at your dose response curve here, if you look at the responses on the lower part of this scale, let's say it's 50% or less, and that is the desired response that you want from your drug, all three of these drugs would give you that effect. Drug A, drug B, and drug C would all reach at least the 50% mark. But if I wanted a response from this particular drug or in my patient that's in the upper range of the dose response curve, up around 80, 90, or 100%, only drug B would give me that effect. This graph shows what's called the duality of partial agonists. You see, in the body, partial agonists can actually have different types of actions. By definition, a partial agonist can stimulate the receptor. It can act as an agonist, after all. This graph is here to show us what happens when a partial agonist is placed in the presence of a full agonist. Obviously, you can start to predict that the partial agonist and the full agonist can compete for the same receptors. Let's take a couple of examples and then we'll go through the graph. The first is the example of the drug Pendolol. You probably recognize Pendolol by the last four letters of its name. OLOL indicates that it's a beta blocker, and that is correct. Pendolol is a beta blocker, but it has the special property of being a partial agonist. That means if you could somehow isolate a heart and add Pendolol to that heart, Pendolol can actually directly stimulate the beta-1 receptors on the heart. It acts as a partial agonist. But of course, an isolated heart preparation is not a whole body experiment. That's not a real situation clinically. What happens in the body when you put Pendolol in somebody's body who already has epinephrine or norepinephrine stimulating that heart? Well, epi and norepi are full agonists. So what happens when you have a full agonist and a partial agonist in the same situation? They compete for those receptors. In fact, the action of Pendolol is going to be to reduce the effect of the full agonist. Think about it this way. Every time Pendolol binds to a beta-1 receptor, epi and norepi can't bind to those same receptors. So the overall effect of your full agonist is going to be reduced. There's really kind of a similar story if you think about the drug tamoxifen. You've learned about tamoxifen perhaps as a SERM, as a selective estrogen receptor modulator, which is kind of a fancy way of saying that tamoxifen acts as a partial agonist. If you were to have a postmenopausal woman, no estrogen in her body, and you gave that woman tamoxifen, it would act as an agonist. It acts as a partial agonist. It would stimulate those estrogen receptors. What if you give tamoxifen to a woman who has estrogen receptor positive breast cancer? If estrogen is stimulating the growth of the breast cancer, and you give that woman tamoxifen, that drug is going to compete for the binding to those estrogen receptors with the estrogen that was stimulating it. Ultimately, tamoxifen in the body, in the presence of estrogen, works as an antagonist. That's probably the most important take-home message. Partial agonists in the body actually work as antagonists. They inhibit the binding of the full agonist. When I look at the graph, typical dose-response curve, notice the partial agonist alone reaches some maximum response that's less than 100%. But the other part of this graph shows what happens if I start with a dose of a full agonist, which is going to be up around 100%, and then I start adding partial agonist into the system. The effect of that full agonist is going to be reduced. In fact, the more partial agonist I add, the greater the reduction in the response I'm going to see. If I keep adding more and more partial agonists, though, the response doesn't go to zero. The response, in fact, only reduces to what the maximum effect of a partial agonist all by itself would be. This is different from if this was truly a competitive antagonist. If this was a pure antagonist, I could block enough receptors to take the response of the full agonist all the way down to nothing. That doesn't happen with a partial agonist. It goes from about, in this case, 100% down to about 50%, which represents what the partial agonist all by itself would do. Kind of a final thought is, in that situation, adding the partial agonist in the presence of a full agonist, if I add enough partial agonist, that's all I'm going to see. I won't see the effect of the full agonist anymore. This graph allows us to talk about the concept of competitive and non-competitive antagonism, and also to look at the concept of potentiation. If you look right in the middle of this graph, you see what's labeled as control. Well, the control in this case is actually the agonist drug. And on the x-axis where it says log dose of the drug, we're actually plotting the log dose of the agonist. So when I look to the right and I see a competitive antagonist, keep in mind that most antagonists are in fact competitive. If we talk about drugs in our review and we say, well, that drug is an antagonist, your assumption is going to be that it's competitive because that's the more common action of a drug. Rarely we're going to see some drugs that are actually non-competitive. If I look at the curve, I notice how the competitive antagonist curve is shifted to the right compared to the control. What this is showing us really is it looks like the potency of the agonist has been decreased because the curve has been shifted to the right. When I give a fixed dose of a competitive antagonist, because of the competitive nature of that drug, I can increase the dose of an agonist and essentially outcompete the competitive antagonist. Did you catch what I just said? If you add more agonist, you can overcome the competitive antagonist. So why does the curve shift to the right? Because I'm using more agonist drug. And that means an increase in the amount, an increase in the dose. That is a shift to the right. Then look at the non-competitive antagonist. Examples of non-competitive antagonists, drugs like phenoxybenzamine. or aspirin, allopurinol, and proton pump inhibitors, and probably others that you can think of. The non-competitive antagonist, notice down at the bottom of my slide, reminds us that many times a non-competitive antagonist is actually binding irreversibly to the receptor. Competitive antagonists, on the other hand, those are reversible binding. They're going to reversibly inhibit the receptor. And it's all about the type of bonding that takes place. A competitive antagonist binds to the receptor through weaker ionic bonds. Non-competitive drugs most often are going to bind by very strong covalent bonds, making them irreversible. Think about it that way, that if I've bound up the receptor with a non-competitive antagonist, I can no longer bind that receptor with an agonist. I have fewer receptors available to bind the agonist. So when I look at the shape of the graph, what a non-competitive drug does is it's going to decrease the maximum response of my agonist. Another way to say that, it decreases efficacy. So when you compare one more time, the competitive antagonist shifts the curve to the right, decreased potency. The non-competitive drug shifts the curve downward, decreasing efficacy. The shape really gives it away. We also have an example of potentiation. Potentiation is rare. There are not a lot of examples, and probably the best example is when you add a benzodiazepine in the presence of GABA. Well, if that's my example of potentiation, what's the control in that case? What's the agonist all by itself? Well, of course, that would be GABA. So imagine GABA is your control, and the example of potentiation is GABA plus a benzodiazepine. In this case, the curve shifts to the left. If you look at the word potentiation, it almost has the word potency built into it. In fact, I'm going to increase potency when I shift to the left. In other words, it doesn't take as much GABA to get the same effect in the presence of a benzodiazepine. That's probably as detailed as we need to get, but some of you already know about mechanisms of these drugs. If you know that benzos, for example, are going to increase the frequency of chloride channel opening, that only happens in the presence of GABA. So benzos are going to help GABA open that channel more often. If we want to summarize the different types of antagonism, we just covered one type, which is called pharmacologic antagonism. Pharmacologic antagonism divides into the two components that we just covered on the previous slide, competitive and non-competitive antagonists. It really implies that you've got an agonist and an antagonist, and they both target the same receptor. I've diagrammed that for you on my slide. So you have an agonist that can stimulate the receptor and an antagonist that can block that receptor, either competitively or non-competitively. The key, two drugs, both of which target one receptor. A second type of antagonism is physiologic antagonism. In this case, you're dealing many times with two different agonists that oppose each other. The text tells you about a vasoconstrictor combined with a vasodilator. How about a real example? Phenylephrine is a potent vasoconstrictor. It works through alpha-1 receptors, whereas nitroglycerin is an important vasodilator working through nitric oxide. Those two actions, even though they're mediated by different receptors and different pathways, those two actions oppose each other. So let's draw a diagram. So agonist 1 stimulates its own receptor. Agonist 2 stimulates its own receptor, and those two receptors oppose each other. And that's what we call physiologic antagonism. You can probably think about maybe the best example, which is the autonomic nervous system. Isn't it true that the sympathetic nervous system opposes the parasympathetic nervous system? Each of those systems uses its own neurotransmitter and different receptors to cause that effect, and they oppose each other. For example, on the heart, muscarinic M2 receptors stimulated by acetylcholine are going to slow the heart down, whereas beta-1 receptors stimulated by norepinephrine are going to increase the heart rate. Opposite effects, that's what we call physiologic antagonism. Our third example is called chemical antagonism. Chemical antagonism is where you have two drugs that actually bind to each other. There is no receptors involved in this interaction. So what you're seeing is a drug-to-drug complex, like you see with protamine binding to heparin. Two drugs acting to bind directly to each other independent of receptors. This is what our chelators do as well. Metal chelators bind up the metal independent of acting through a receptor. Let's summarize the three types of antagonism. The way that you can figure out pretty quickly what type of antagonism you're dealing with, you're always going to have two drugs. It's the number of receptors that's going to vary. So if I have two drugs and they bind to each other with no receptors involved, that's chemical antagonism. If I have two drugs, one stimulates the receptor and the other blocks that same receptor. Two drugs and one receptor, that's pharmacologic antagonism. But if I have two drugs and two different receptors, and the two receptors oppose each other, that's physiologic antagonism. Next we have what's called quantal, also called cumulative dose-response curves. I actually happen to not like either of those terms. I tend to refer to these graphs as population curves, and that's the key. These are graphs that are going to look at the percentage of the population that responds to your drug. It's this type of curve where you can estimate an ED50, the effective dose in 50% of the population, and also a toxic dose to 50% of the population. So when I look at the graph, once again I'm plotting dose, but this time versus the percent of patients responding. In this type of population graph, I can look at a therapeutic curve or a toxic curve. And it's from looking at those graphs, I can calculate a therapeutic index, which is formed by the toxic dose in 50% of the patients divided by the effective dose in 50% of the patients. Notice the alternate equation is LD50. LD stands for lethal dose 50. Those are obviously not experiments that we do very commonly. Have a hard time getting people to volunteer for those types of experiments. But TD50 over ED50, that's what you should concentrate on. So can you calculate the therapeutic index given this graph right here? Sure you can. If you look at the therapeutic curve, if you go to the 50% mark, go over to the curve for therapeutic and come down to the x-axis, you see it corresponds to 2 milligrams per kilogram. You do the same thing for the toxic curve, go up to 50%, go over and come down, you see that it corresponds to 10 milligrams per kilogram. So what's your therapeutic index? 10 divided by 2, which equals 5. The therapeutic index for this drug is 5. If you think about what that really means, it really means that if you take 5 times the recommended amount of the drug, on average you're going to get toxicity. You tell your patient to take one of these pills once a day and they say, nah, I'm going to take 5. Chances are good, given that this is the example we're talking about, that they're going to get toxicity. Again, some people do that, right? Don't people take more drug than we recommend? I call it the just-in-case rule. Not sure if you're familiar with this. I didn't know this, but for years I discovered that my father actually practiced the just-in-case rule. He once told me, I was taking some ibuprofen, and he once asked me why I was taking 2 ibuprofen. I said, because I have a headache. And he says, why just take 2? He says, take 4, just in case. And that actually explained a lot about what was going on and some of the troubles we were having with his medication. But if that's what your patient thinks, that more is better, what if it's this example? They say, well, I'm going to take 5 times what the doctor recommends. Well, you're going to get toxicity. So clearly, in order to be a safer drug, you want it to have a higher therapeutic index. The larger the number, the safer the drug is. That means the farther away your toxic dose is from your effective dose. If you look at a graph, that means the safer drugs are the ones where the curves are spread farther apart, and the more dangerous drugs are where the curves get close together. So what if I take toxic dose 50 divided by effective dose 50 and I get a number like 2 or less? Those are my really low therapeutic index drugs. Those are some of our most dangerous drugs. And here's a list of some of those that actually become very popular step 1 questions. Theophylline, digoxin, warfarin, lithium. All are drugs with a low therapeutic index. That means in a drug interaction question, if I have a P450 inhibitor in theophylline, remember the example from earlier? Theophyline's plasma levels are going to be higher. And that would be the case for a lot of drugs, but why is it that theophylline shows up in the test question, or digoxin or warfarin show up in those test questions? That's because those are more dangerous drugs, and raising their plasma levels even slightly can lead to significant side effects, significant and possibly fatal side effects, making them better candidates for test questions. This table looks at drug development and testing. Really gives us an opportunity to talk about clinical trials. It's possible that you can get a question on your exam related to clinical trials. Mostly you need to pay attention to the design of the trial and the purpose of the trial. Before we put a drug into clinical trials, we do preclinical trials on animal models, and sometimes those studies can last for a number of years. But focus most of your time on the 4 phases of clinical trials. When I think about phase 1 testing, first of all, phase 1 is done in healthy volunteers. People volunteer. Occasionally we will pay these folks, but they will volunteer to be a part of phase 1 trials. Notice, since it's healthy volunteers, there's no way that you're testing for efficacy at this point. The only thing that you can test in these healthy volunteers is safety in dosage. To say it another way, the purpose of phase 1 is to find a safe dosage to move on into phase 2. But we're doing that in healthy patients. We're doing that in healthy people. Phase 2 trials typically are the first time that we're going to test the drug out in patients. The numbers go up. Now we're talking about hundreds of folks involved in a phase 2 trial. Since we're dealing with patients, we can evaluate effectiveness. Phase 2 typically is the first time we test for efficacy. How about this question? What phase of clinical trials do most drugs fail? The answer is phase 2. Most drugs that enter clinical trials will fail in phase 2. In fact, if they make it through phase 2, we're going to do an even more extensive study on those drugs, but if they fail in phase 2, typically that is the end of that drug. We get through phase 2, we found that the drug was effective. Now we do a more extensive phase 3 trial, typically with thousands of patients. The purpose of phase 3 is to confirm the effectiveness in a larger patient population and also to look for common side effects. Keep in mind, it has to be common side effects because you're only talking about a couple of thousand patients. You're never going to see the rare side effects occur with such a small patient population. When the drug makes it through a phase 3 trial, it undergoes a review by the FDA. If it's approved by the FDA, it then goes into phase 4 trials, what's called a post-marketing surveillance. This happens after the drug has been approved to go out on the market, and now patients are taking this drug and physicians are prescribing it. In fact, this is an opportunity for the average physician to possibly get involved in clinical trials. They can volunteer to be a part of collecting data in phase 4. Importantly, the purpose of phase 4 trials can determine the common side effects, really confirming some of those that we might have seen in phase 3, but also to discover rare side effects. This is that time when side effects that occur in, let's say, 1 in 10,000 or 1 in 100,000 patients are discovered, because this is the only time that we're getting a large enough sample size to detect those rare side effects. It's why some people advocate that you should wait at least 3 to 5 years after a drug goes out onto the market before you begin prescribing it to your patients. That's going to be a hard rule to follow, by the way. A lot of pressure on you by your patients to prescribe these new medications. But why would you wait 3 to 5 years to start prescribing a drug? Clearly, it's because we don't have enough data about rare side effects. And some of you might remember the lesson learned from years back with the COX-2 inhibitors. Where as popular as they were when they first hit the market, while we were doing our phase 4 trials, we discovered some rare side effects that those drugs may cause, rare side effects like death. We have a table on teratogenicity. It's basically how the FDA classifies drugs and their pregnancy categories and their pregnancy risks. We have 5 different categories that we're going to use: A, B, C, D, and X. Of course, this is all based on data that we've collected either in animals or in humans, and hopefully both. When you think about a drug and we call it category A, those drugs are considered very safe in pregnancy. That's the good news. The bad news is that almost nothing is in category A. You know what's in category A? Folic acid. That's right. You're pregnant, folic acid. We're willing to give you folic acid. Pretty much folic acid and water is about what we're willing to give you in pregnancy. Folic acid, very safe in pregnancy. We have drugs that are categorized as B, which are considered safe in pregnancy. But of course, this is where it starts to get scary. Look at C. Category C drugs may be safe. If you look at the table, notice how it shows you that there are no studies available in humans. And that's kind of scary. Well, why does a drug get put into category C? I call it the unknown category. If we don't know anything about a drug's teratogenic risk, we tend to put it into category C. If we learn over time that the drug is safe in pregnancy, we might move it up, let's say, to category B. But if we discover that the drug is harmful to the fetus, then we drop it down into D or X. And if you're thinking, how can we have a category where it's unknown, where we don't have the data? Well, how often do you think pregnant women are volunteering for clinical trials? Very, very difficult to collect this data, so it's a slow process over time. Once you get down to category D or category X, those are teratogenic drugs. Those are drugs, we have human studies that show those drugs have caused harm to the fetus. But there is a difference in how category D and category X are viewed in terms of your patient. For example, a category D drug, you might decide to actually continue your pregnant patient on that category D drug only if the benefits of that drug to the patient outweigh the risks to the fetus. An example would be if you don't have any suitable alternatives to treat their condition. But with category X, you immediately discontinue the medication. Don't even think about continuing a patient on a category X type drug. Immediately discontinue. Again, both are harmful to the fetus, and we're going to talk about some examples in the rest of our lectures of drugs that are teratogenic, and if we know the specific teratogenic effects, those all make for very good test questions. Now that we finished Chapter 2, let's do a few practice questions together. Here's the first one. This is an opportunity for you to pause the video, review the question, think about it, come up with a correct answer, and then we'll discuss. So here we've got 4 drugs. They produce the same therapeutic effect by the same mechanism, but each has a unique toxicity. We're trying to figure out which drug is likely to have the highest incidence of toxicity. When I look at the data that's presented, I'm looking for information that helps me to determine toxicity risk for the drug. Median effective dose really doesn't tell me that, but TD50 over ED50 actually does, because that's my therapeutic index. And the rule on therapeutic index is the lower the number, the more dangerous the drug. By that rule, that would be choice B. 2.1 is the lowest number. That would be the most dangerous drug. That would be the one with the highest incidence of toxicity. But some of you still focused on the other column, median effective dose. And you saw numbers like 0.5 and 1 and 5 and 33. Really what those numbers are probably reflecting is more the potency of the drug. Drug A is more potent than B, and B is more potent than C, which is more potent than D, because it takes smaller amounts of those drugs to produce their effectiveness. So as a result, the first column is really not helpful in answering this question. Don't let it influence your choice of which drug has the highest incidence of toxicity. Here's our second question. Once again, pause the video. We will discuss. So, serious, possibly fatal adverse effects of a new drug may first appear only after the drug is approved for marketing by the Food and Drug Administration. The failure to detect these effects is best explained by the use of which of the following in the pre-marketing clinical trials. Remember, the fact that we don't see those side effects ultimately until the drug has gone out on the market is because the clinical trials in phase 1 and phase 2 and phase 3 have used a very, very small number of patients. The only way that you're going to detect rare side effects is when you have a much larger patient population and that only happens in phase 4, the post-marketing surveillance studies that we do. So the correct answer here is E. There were just too few subjects to detect those rare events. Here's our third question. Once again, pause the video, review the question, and we will discuss. Leukotrienes are implicated in asthma, and they act via leukotriene receptors to cause bronchoconstriction. Albuterol, acting through beta-2 receptors, can oppose the actions of leukotrienes by causing bronchodilation. We want to know what term best describes this effect. If you go back earlier and we talked about the different types of antagonism, leukotrienes have their own receptor. Albuterol has its own receptor. You have 2 receptors, and the 2 receptors do opposite things. A 2-receptor system is what we call a physiologic antagonist. Choice C is the correct answer. Remember, if it was chemical means that leukotrienes and albuterol actually bind to each other, and we know that that's not true. If it was pharmacologic, that means that leukotrienes and albuterol would be working on the same receptor, and we know that that is also not true. The next thing we're going to review are various signaling mechanisms. It's a good opportunity to bridge the biochemistry that you've learned with the pharmacology. We think about the different types of receptors and those signaling pathways. So we start with intracellular receptors, including receptors for steroids. So steroids can diffuse across the cell membrane. They can bind to their intracellular receptor. That drug receptor complex goes to the nucleus and stimulates gene expression. So when you think about steroids binding to intracellular receptors, this is a gene expression pathway. What I would have you think about is, how rapid of a response do you get to steroids? If steroids involve changes in gene expression, those responses are going to be slower to occur. In fact, let's make sure that we highlight that part of this text. The response to steroids, slow in onset, but long in duration. You see, once you form new proteins with the steroids, they tend to have a long-lasting effect. We have membrane receptors that are directly coupled to ion channels. If the receptor is directly coupled to an ion channel, you have to imagine this is a very rapid responding system, certainly as compared to the steroids, which involve changes in gene expression. Here, when the drug binds to its receptor, you're going to see changes in ion channels. For example, a sodium channel is going to open up and sodium is going to rush into cells. This action occurs completely independent of second messengers. Some examples of ion channel coupled receptors: nicotinic receptors. When acetylcholine stimulates a nicotinic receptor, you're going to see the opening of a sodium and potassium channel, where sodium goes into the cell and potassium is going to exit the cell. Another example would be GABA A receptors. When you stimulate those GABA A receptors, they're directly coupled to chloride channels, and a number of drugs can modulate that activity. We have receptors that are linked via coupling proteins to intracellular receptors. What we're basically talking about here are G proteins. You've learned a lot about G proteins. The challenge for us right now is to make sure that you can take what you know about G proteins, couple those directly to certain receptors, and then couple that with the drugs that either stimulate or block those receptors. There are 3 main types of G proteins that we discuss. On this slide you see GS and GI. Remember that these types of G proteins are opposite of each other. They both work through adenylyl cyclase, but GS, of course, are stimulatory G proteins. They're going to activate adenylyl cyclase to increase cyclic AMP production. It's actually similar to the action of the toxin from Vibrio cholera. Cholera toxin is going to increase cyclic AMP levels. What you have to do when you relate G proteins to the pharmacology is you have to tie the G protein to its receptor. There are a lot of receptors that are going to use GS pathways, but betas are really the most important for us to focus on right now. So the rule is all betas are GS. That would be beta 1, beta 2, and beta 3 receptors all work through GS proteins. GI, on the other hand, inhibitory G proteins are going to inhibit adenylyl cyclase. They're going to decrease cyclic AMP. Once again, exactly the opposite of GS. When I see that decrease in cyclic AMP through GI-coupled pathways, I'm going to have inhibitory effects on cells. Importantly, receptors that you have to know that are GI-coupled: alpha-2, muscarinic M2, and dopamine D2. The third type of G protein is the GQ pathway. GQ is totally different from GS and GI because it doesn't involve adenylyl cyclase or cyclic AMP. GQ is the pathway that's going to activate phospholipase C. Phospholipase C is an enzyme that's going to cleave membrane phospholipids, releasing the second messengers IP3 and diacylglycerol. IP3, of course, releases calcium from the SR, whereas DAG activates protein kinase C. Receptors that you have to match up with GQ would include the muscarinic M1 and M3 receptors and alpha-1 receptors. Here's a cartoon that diagrams exactly how phospholipase C is going to work on this molecule. In fact, if you ask yourself, what have I drawn here? What is this cartoon actually representing? It's representing phosphatidylinositol. You see the glycerol backbone, you see the two fatty acids, you see the polar head group there with inositol attached to it. Well, phospholipase C is going to cleave between the phosphate and the glycerol backbone. That's going to release inositol phosphate, which becomes IP3. IP3 then goes and releases calcium from the SR. What's left is glycerol with two fatty acids, and we call that diacylglycerol. In fact, it's not a bad opportunity for you to review the different types of phospholipases here. In fact, if I ask you, what is the phospholipase that cleaves off the first fatty acid here at the top of the diagram? That would be phospholipase A1. What's the name of the phospholipase that cleaves off the second fatty acid? Well, that's phospholipase A2. In fact, what fatty acid is normally found off of that second carbon? Well, phospholipase A2 releases arachidonic acid. That's part of the arachidonic acid cascade. So many times you find arachidonic acid in that location. We see where phospholipase C works on the other side of the phosphate. Between the phosphate and inositol, that's actually where phospholipase D works. I don't know about you, but I've always had this question in my mind. If we have phospholipase A1, A2, C, and D, what's the question, folks? Where's the B? Well, of course, biochemists name the enzyme. Biochemists are going to reserve the B for biochemistry. So there's no B. There's just A1 and A2. Then there's C and D. This diagram shows us the different types of G proteins and also gives us an opportunity to look at their signaling pathways in a little bit more detail. So starting on the left, we see the molecule adenylyl cyclase. If I'm talking about a GS-coupled receptor, that receptor, when I activate adenylyl cyclase to produce cyclic AMP is going to then activate protein kinase A. It's important to remember the kinase in these pathways. And of course, the easy way to remember, it's A for the kinase, it's cyclic AMP, and A is also for adenylyl. GI, on the other hand, GI are inhibitory G proteins. They decrease the activity of adenylyl cyclase. Cyclic AMP levels go down. You inhibit the activation of protein kinase A. On the right, we see the GQ-coupled pathways, which involve phospholipase C. You see the cleaving of membrane lipids producing IP3, which releases calcium from the SR, and diacylglycerol, which activates protein kinase C. Protein kinase C goes with phospholipase C. When we think about the different types of receptors that are coupled to G proteins, rule number 1, all betas are GS. Rule number 2, if you take the 3 receptors that we've discussed, M2, alpha-2, and D2, you can remember the MAD2s. They're all inhibitory G protein coupled. Rule number 3 says most of my sub-1s and muscarinic M3s are GQ. Let's look at some examples of the sub-1s. Obviously, alpha-1, M1. The angiotensin II receptor is called AT1. It's always a little confusing. AT1 is an abbreviation for the angiotensin II type 1 receptor, and that, of course, is GQ coupled. The vasopressin V1 receptor, that's GQ, and the histamine H1 receptor, that's also GQ. So most sub-1s and M3s are GQ. Then there are a few that I call oddballs. There are receptors that don't fit into this pattern. Notice D1, histamine H2, and the vasopressin V2 receptor. Those are actually all GS coupled. So when you go back and summarize GS, it's all betas, but then it's D1, H2, and V2. Cyclic GMP and nitric oxide. Very important pathways because cyclic GMP is a second messenger in vascular smooth muscle. In fact, later on, when we're going through our cardiovascular drugs, we're going to look at exactly how cyclic GMP can relax smooth muscle. I've got a great diagram coming up later on in the lectures. But for now, what I'm going to do is I'm going to tell you the end of the story. I don't know if you've ever done that. Do you ever buy a book and sometimes you read the last chapter of the book just so you know how it ends to see if you really want to read the whole thing? I'm going to tell you the end of the story, and then later on I'm going to tell you the entire story about cyclic GMP and nitric oxide. So how does nitric oxide relax smooth muscle? It ends up causing dephosphorylation of myosin light chains. That's the final step, dephosphorylation of myosin light chains. We'll tell the rest of the story later on. You know, we have a couple of endogenous compounds, like bradykinin and histamine. Bradykinin and histamine are both vasodilators, and at least part of their vasodilating action is mediated through nitric oxide. We have receptors that function as enzymes or transporters. If you look at the long list of enzymes and transporters on this slide, you know, many of those are important. Many of those show up on your Step 1 exam. The way that we're going to deal with those is one at a time. As we go through the remainder of the lectures, we're going to go through each of those and talk about why that's important for your test. We have receptors that function as transmembrane enzymes. Importantly, this is how insulin signals and a couple of growth factors, epidermal growth factor and platelet-derived growth factor. These pathways for insulin and these two growth factors involve tyrosine kinase activity. That's important. Ultimately, the binding of the ligand causes a conformational change that causes these receptors to dimerize. The tyrosine kinase domains become activated, and then we're going to phosphorylate tissue-specific substrate proteins. In the margin is a clinical correlate about a couple of tyrosine kinase inhibitors. This pathway has become a very popular target for a number of drugs. We've got the drug imatinib, a very specific tyrosine kinase inhibitor, whereas sorafenib is a non-specific tyrosine kinase inhibitor. Both of these drugs will be discussed later on in our lectures. The final receptors that we're going to look at are receptors for cytokines. You should think about things like erythropoietin, somatotropin, interferons. This is what we call the JAK-STAT pathway. JAK stands for Janus Activated Kinase. In fact, this is what I call the insulin-like part of this pathway, because JAK is a type of tyrosine kinase. The difference between this pathway, however, and insulin is that the tyrosine kinase for the insulin receptor is intrinsic. It's built into the receptor itself, whereas JAK is a distinct molecule. JAK is a separate molecule from the receptor for the cytokine. JAKs are going to phosphorylate STATs. STATs are signal transducers and activators of transcription. STATs are very steroid-like because they mediate the gene expression part of this receptor. So if I were to put those two pieces together, how would you describe a cytokine receptor? It's like an insulin receptor has combined with a steroid receptor. I've got a tyrosine kinase activity with gene expression. JAK is a separate molecule, STAT is a separate molecule, and both are distinct from the receptor.